strategi yang akan diwujudkan oleh Kementerian Kesehatan untuk memperkuat sistem kesehatan ini adalah penguatan sistem manajemen mutu melalui proses-proses yang sekarang kita tahu tentang perizinan ya, yang kemudian diterjemahkan sebagai perizinan berusaha, kemudian lisensi, sertifikasi serta akreditasi itu sendiri. Ketiga strategi ini, Bapak-bapak dan Ibu-ibu sekalian, diharapkan akan menjadi muara terlaksananya proses-proses penyelenggaraan akreditasi fasilitas pelayanan kesehatan yang merata di seluruh wilayah Indonesia, sehingga terlaksananya berbagai upaya peningkatan mutu dan keselamatan pasien ini bisa yang menjadi cita-cita kita bersama dapat kita laksanakan. Bapak-bapak dan Ibu-ibu sekalian, seluruh peserta webinar yang saya hormati dan saya cintai, 1 tahun sejak WHO menetapkan pandemi Covid-19 dan demikian juga pemerintah Indonesia menetapkan sebagai kedaruratan kesehatan masyarakat dan bencana non-alam, penyebaran Covid sebagai bencana nasional telah kita rasakan bersama ya, berbagai masalah kita dapatkan dan terutama dikaitkan dengan mutu dan keselamatan pasien di berbagai fasilitas pelayanan kesehatan. Tadi juga sudah sedikit disampaikan oleh Dr. Bambang. Rumah sakit yang memberikan pelayanan pada COVID-19 termasuk juga fasilitas pelayanan kesehatan lain memiliki berbagai macam keterbatasan seperti sarana, prasarana, alat kesehatan, kemudian bagaimana kita juga harus memastikan tenaga kesehatan yang terlatih untuk merawat pasien serta berbagai kondisi yang ada. Jadi ini adalah beberapa kendala-kendala yang kita dapatkan bersama pada kondisi pandemi COVID-19 ini. Tentu saja keterbatasan jumlah tenaga kesehatan yang melayani pasien COVID ini juga akan meningkatkan risiko paparan virus dan tekanan kerja pada tenaga kesehatan. Ya, jadi kalau kita mengacu pada tema dari World Patient Safety Day tahun yang lalu, bagaimana kita harus melindungi tenaga kesehatan, karena memang pada dasarnya tenaga kesehatan yang memberikan pelayanan pasien COVID ini memiliki risiko paparan virus yang cukup tinggi kaitannya dengan pandemi COVID ini, termasuk tekanan-tekanan pekerjaan yang dialami oleh tenaga-tenaga kesehatan. Dan juga kita rasakan bersama Bapak-bapak dan Ibu-ibu sekalian, tidak jarang teman-teman kita yang ada di garda terdepan pelayanan COVID ini juga mengalami berbagai macam kekerasan verbal maupun secara fisik ya, baik itu oleh pasien atau keluarga yang karena memang kondisinya sering tidak bisa menerima kondisi COVID yang mereka alami. Dan para tenaga kesehatan ini yang berada di garda terdepan juga harus menerima stigma yang dianggap sebagai sumber penularan di masyarakat. Jadi ini menjadi PR kita bersama, bagaimana kita bisa memberikan perlindungan kepada tenaga kesehatan, sehingga juga tenaga kesehatan juga menjadi nyaman di dalam memberikan pelayanan pada pasien-pasien yang ada. Tentu saja kemudian orientasi keselamatan pasien ini bisa diberikan oleh seluruh tenaga kesehatan yang memberikan pelayanan pada masa pandemi COVID ini. Bapak-bapak dan ibu-ibu sekalian, satu hal yang juga menjadi catatan kita bersama bahwa pada masa pandemi ini pelayanan kesehatan esensial ya, seperti bagaimana kita harus memberikan pelayanan sesuai dengan visi misi rumah sakit yang ada, bagaimana pelayanan-pelayanan yang menjadi program prioritas nasional begitu, misalnya tentang kita harus menurunkan AKI, kita harus menurunkan AKB, bagaimana kita harus menangani bersama penyakit-penyakit katastrofik ini kita rasakan menjadi sesuatu yang tertunda karena kita kemudian terlalu fokus pada pelayanan-pelayanan COVID-19 ini. Demikian juga hal tersebut terjadi karena memang terjadi beberapa relaksasi pelayanan-pelayanan sehingga beberapa klinik rawat jalan misalnya atau beberapa prosedur pelayanan elektif di fasilitas pelayanan kesehatan itu dilakukan penundaan ataupun dilakukan pengurangan kapasitas pelayanan. Bapak-bapak dan ibu-ibu sekalian, pada saat ini Kementerian Kesehatan menetapkan ada empat strategi yang dikembangkan oleh Kementerian Kesehatan pada situasi saat ini ya, menghadapi pandemi ini. Jadi yang pertama seperti kita ketahui, kita terus-menerus harus memastikan kapasitas perawatan pasien ini mencukupi begitu ya. Jadi ini yang terus-menerus menjadi arahan dari Bapak Menteri Kesehatan untuk memastikan kapasitas perawatan pasien COVID ini mencukupi untuk menampung pasien-pasien yang ada. Strategi kedua yaitu melakukan relaksasi kebijakan khususnya terkait dengan kebijakan-kebijakan registrasi sertifikasi begitu ya untuk tenaga-tenaga kesehatan. Jadi ini untuk memenuhi berbagai macam kebutuhan terhadap tenaga-tenaga kesehatan pada masa pandemi COVID-19 ini. Kemudian strategi yang ketiga yang ditetapkan oleh Kementerian Kesehatan yaitu penguatan sistem rujukan ya. Jadi bagaimana kemudian sistem rujukan secara horizontal ataupun secara vertikal, bagaimana dari karantina terpusat ke rumah sakit dan sebagainya ini menjadi sebuah sistem yang rujukan yang betul-betul terintegrasi. Kemudian strategi yang keempat, ini saya kira yang sangat-sangat relevan dengan apa yang diadakan pada siang hari ini, yaitu melalui penguatan mutu fasilitas pelayanan kesehatan dalam menghadapi pandemi COVID-19 ini, baik melalui upaya-upaya tidak hanya kuratif, rehabilitatif, tetapi juga upaya-upaya yang cukup komprehensif, termasuk upaya-upaya promotif serta preventif, serta berbagai kegiatan-kegiatan surveillance yang ada. Bapak-bapak dan ibu-ibu sekalian, di saat pandemi COVID ini, pemerintah juga melakukan selain tadi beberapa strategi yang sudah dilakukan, ada satu relaksasi yang saya kira juga perlu saya tekankan pada pertemuan siang hari ini, yaitu tentang kebijakan penundaan akreditasi, begitu ya, seperti disampaikan oleh Bapak Menteri Kesehatan waktu lalu melalui surat edaran 455. Penundaan akreditasi ini akan dilakukan hingga nanti status bencana nasional pandemi COVID-19 ini dinyatakan dicabut oleh pemerintah. Apakah kemudian dengan relaksasi yang ditetapkan oleh yang dijadikan kebijakan oleh pemerintah itu kemudian akan membuat kita semua gitu ya menunda berbagai macam upaya penjaminan mutu di masa pandemi COVID-19 ini. Ini menjadi tantangan untuk kita semua bahwa walaupun akreditasi ini ditunda, tetapi semangat untuk membangun mutu pelayanan pada masa pandemi tidak pernah padam. Tentu saja kita semua harus sepakat untuk menjawab tidak gitu ya. Jadi upaya penjaminan mutu di masa pandemi harus tetap kita jalankan bersama. Karena mutu dan keselamatan pasien tidak boleh ditawar dalam kondisi apapun. Bapak-bapak dan ibu-ibu sekalian, untuk itu dalam penyediaan pelayanan yang optimal, terutama untuk pasien yang terkonfirmasi COVID-19, jadi ini yang terkonfirmasi COVID-19, dan untuk memperlambat serta menghentikan laju penularan, menunda penyebaran penularan, serta memberikan pelayanan kesehatan yang bermutu dan memperhatikan keselamatan pasien, maka Kementerian Kesehatan beberapa waktu yang lalu telah menetapkan pedoman pemantauan dan evaluasi kesiapan rumah sakit pada masa pandemi COVID-19 dengan mengadop daftar tilik dari WHO, Hospital Readiness Checklist for COVID-19 yang mencakup 12 komponen, baik itu bagaimana tata kelola manajemen ataupun tata kelola klinis. Proses yang sama pada kesempatan ini juga kami sampaikan bahwa kami di Kementerian Kesehatan juga sedang mempersiapkan laboratorium readiness ya, karena memang ini laboratorium ini menjadi fungsi yang sangat sentral pada kondisi pandemi COVID-19 ini, sehingga satu instrumen yang sedang kami siapkan juga tentang laboratorium readiness. Nanti mudah-mudahan bermanfaat untuk kita semua. Bapak-bapak dan ibu-ibu sekalian, di dalam pedoman monitoring evaluasi kesiapan rumah sakit yang saat ini alhamdulillah sudah direspon sangat baik oleh rumah sakit yang ada di seluruh wilayah Indonesia, diharapkan dapat digunakan sebagai acuan baik itu oleh pemerintah sebagai lembaga representasi pemberi izin, fasilitas pelayanan kesehatan itu sendiri, tentu saja rumah sakit, dan seluruh pemangku kesehatan, pemangku kepentingan lainnya dalam mendukung kesiapan fasilitas pelayanan kesehatan dalam menghadapi pandemi COVID-19 ini. Selain daripada itu, dengan pedoman ini juga diharapkan dapat mengoptimalkan kemampuan rumah sakit sebagai bagian dari komitmen untuk menjaga dan meningkatkan mutu pelayanan. Jadi ini kalau dikaitkan tadi dengan kebijakan untuk penundaan akreditasi sesuai dengan surat edaran 455 dari Bapak Menteri Kesehatan yang lalu. Upaya-upaya penguatan mutu pelayanan fasilitas pelayanan kesehatan yang berfokus pada keselamatan pasien, terutama sekali lagi pada masa pandemi Covid-19 ini merupakan tanggung jawab kita bersama, gitu ya. Tanggung jawab kita bersama, baik itu pemerintah dari pusat sampai pemerintah daerah, pemilik fasilitas pelayanan kesehatan, pelaku-pelaku di fasilitas pelayanan kesehatan, dan tentu saja seluruh stakeholder yang terkait. Hadirin yang saya hormati, seluruh peserta webinar kali ini, kami mengucapkan terima kasih kepada Komite Nasional Keselamatan Pasien yang sudah untuk kesekian kalinya ya ini mengadakan kegiatan webinar atas kerjasamanya yang sangat-sangat baik sehingga webinar ini dapat terselenggara secara maksimal. Thank you special for to Catherine, Leonhardt, and Francine for your sharing the implementation of quality and patient safety and facility management and safety in healthcare. We hope that it will be very useful for all healthcare in Indonesia, both primary and referral healthcare. Dan dengan mengucap Bismillahirrohmanirrohim, dengan ini webinar peningkatan mutu dan keselamatan pasien yang merupakan kerjasama antara Kementerian Kesehatan, Komite Nasional Keselamatan Pasien, dan Joint Commission Internasional secara resmi saya buka. Dan semoga Allah Subhanahu wa Ta'ala senantiasa menyertai langkah-langkah kita semua. Amin, amin, ya Robbal Amin. Sekali lagi terima kasih dan wassalamualaikum warahmatullahi wabarakatuh. Atas nama Bapak Direktur Jenderal Pelayanan Kesehatan, Profesor Dr. Abdul Qadir, PhD, SPTHT, AL, Mas. Terima kasih dan wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Kami sampaikan terima kasih pada Dr. Gigi Fariha Hanum MKes. Luar biasa sekali ya Bu ya, memang tugas kita pada masa pandemi ini luar biasa sekali. Oke, baik. Selanjutnya memasuki acara inti, yaitu pemaparan materi oleh panelis sekaligus diskusi dan tanya jawab, yang kali ini dipandu secara langsung oleh Dr. Dini Handayani Mars selaku moderator. Kepada Dr. Dini, kami persilakan.
Terima kasih, Mbak.
Ya, sebelumnya boleh saya sampaikan satu pengumuman Dr. Dini, lupa tadi. Ya, Bapak Ibu sekalian, untuk teman-teman yang tidak dapat bergabung pada link Zoom ini, dapat bergabung di akun YouTube kami di Peningkatan Mutu Pelayanan Kesehatan. Nanti sudah ada yang live di sana. Baik, kepada Dr. Dini kami persilakan.
Terima kasih Mbak Evi. Selamat siang semuanya. Assalamualaikum warahmatullahi wabarakatuh. Puji syukur bagi kita semua. Om Swastiastu. Salam kebajikan, namo budaya. Sebelum saya memulai acara ini, mungkin saya ingin meminta perwakilan dari GCI Asia Pasifik untuk memberikan sambutan. Mungkin saya akan meminta Managing Director dari Asia Pasifik, Mr. John Yoon. So, Mr. John Yoon, I hope you are with me now. I would like you to give a brief opening for everyone this afternoon before we start the meeting. So, please, the floor is yours.
Hello.
Hello. Yeah, we can
hear you. Yes, I hope everyone can hear me. Thank you so much for the wonderful introduction. I think it's really nice to see everyone. As some of you know, we also had another meeting yesterday with Dr. Hanum and many of you. So it's really nice to see everyone back here again. I do see that there's a lot of work to do. I was very impressed by Dr. Hanum's presentation yesterday, and some of that was obviously repeated today. with some of the goals that you're trying to achieve in terms of patient safety and quality. And we are very grateful to be part of your journey. And I hope this webinar today could be one of those resources that we can provide you to help you to get to that goal, closer to that goal. So thank you so much for your kind opportunity. I want to thank Dr. Dini and Nick for all the coordination that went through to make this possible. And I really want to appreciate Dr. Catherine Leonhardt and Francine Westergaard. They're absolutely one of the best consultants that JCI is very proud to have. And I hope their content today will provide absolutely amazing learning experience for you. But thank you so much for all your time and participation.
Okay, thank you, John. So, mohon izin Bu Hanum, kita akan mulai webinar ini untuk pembicara pertama. So, the first presentation will be from Francine Westergaard. From Catherine Leonhardt. Sorry. So, I will give a brief introduction about Catherine. So, Catherine is our JCI Principal Consultant. Her education will be Doctor of Medicine from University of Michigan Medical School, USA. And then also she followed a Master of Public Health in Epidemiology, University of California, Berkeley, California. Also a Bachelor of
Sama aja.
Also Bachelor of College in Massachusetts, USA. So she has a lot of professional experience, including the leadership roles in healthcare providers organizations, including patient safety officers, vice president, and medical director. And also, she also the academic appointments in School of Medicine and Healthcare Sciences, and also the position in the government and nonprofit health agencies, including deputy director and consultant. Her professional affiliations or certification will be a Certified of American Board of Preventive Medicine, Certified Professional in Healthcare Quality, GPHQ, Certified Professionals in Patient Safety, and RPI Yellow Belt from the Joint Commission, and teams from STE PPS Master Trainer, and also Patient Safety Leadership Fellowship. So he has a lot of list and a lot of experience, of course, for almost over 25 years in healthcare administrations. So time and floor is yours, Catherine.
Thank you, Dr. Dini, and thank you all for the opportunity to share with you. I'm going to do a little check. I'm getting some feedback and see if that maybe we can make sure everyone's on mute so that we don't have that feedback.
Yeah.
Okay.
Okay.
Great. Dini, if you'll also share, how will you do some?
Do you want to share it yourself, or this is yours, right?
I'm going to share my screen, but are you going to do any translation?
No. So please
Okay.
just go through with all the presentations, and the translations will be provided during the Q&A sessions.
Great. So I'll just speak slow and make sure if there's any questions, please raise your hand or enter through the chat, and Dini will facilitate.
Thank you.
Great. Thanks. So great. I'm not getting any feedback. I'm going to continue with my slides and my presentation. So thanks again. Wonderful to be with you. I have been in Indonesia before, and actually there's someone in the audience that I've worked with in the past. So really a wonderful opportunity to share with you my story about my perspective on the future of healthcare quality and how accreditation is going to take us there. I started my career, as Dr. Dini said, a long time ago, 30 years ago, and I started during the epidemic of another new novel virus called HIV. We learned a lot from HIV in the 1980s. In fact, that's where universal precautions and the use of gloves first became part of our routine care. So we are learning a lot from COVID. We know we're going to have a lot of lessons learned. But I really look at quality and safety as a continuous improvement project. This pandemic, unfortunately, is going to be another milestone in our continuous improvement as we adjust and innovate in quality and safety. And we have learned so much about that, as well as the role of accreditation. So as we walk through this presentation, I really look at it as a roadmap, which is consistent with your theme of this webinar, strengthening your quality in your facilities during the pandemic. So by the end of this presentation, you're going to have learned some new information. You're going to identify some questions that you can take back to your facility to assess your current state of quality and safety. And I'm going to give you some tools of things that you can use to identify these 3 steps. Where are you going? Selecting your goals and your aims, identifying what you need to get there, how to build your quality program, and to determine how you're going to reach that destination. So as we start this roadmap, this journey, I also want you to think about the future. So imagine it's the future. You're the CEO or the quality director of your facility. COVID-19 is under control, and you've built a strong quality program. Your quality measures have met their target. Your patient satisfaction scores are higher than any other facility in the region. And you have 0 patient harm. And as a bonus, your facility is JCI accredited. Wow, that would be a great future state. So let's move forward on this journey and figure out how you're going to get there. Well, we have to start with today. We are still in the midst of a pandemic. We all have our stories. You've all struggled with managing the influx of patients, the limited supplies of PPE, the new ways of providing care that protects your patients as well as your staff. We've all been challenged during this pandemic with so many different aspects of quality and safety. In fact, Joint Commission conducted a survey in September of last year to understand what have been the most common challenges of organizations around the globe as we struggle through this pandemic. And we've identified that the most common challenges are over on the left side of your screen. Activities around staff retention, the emotional response, as well as supplies, getting those PPE equipment, and having shortages of things like ventilators. We've also struggled across the globe with organizational changes, maintaining protocols and policies on how we manage patients, how we move the patients through our facilities. And at first, we were really struggling with how to take care of our clinical needs of our patients. But what's happened more recently is we've become overwhelmed with too much information. In a recent study, it was identified at one point last year, there were over 2,000 publications on COVID per week. So how are we able to keep up with all this information while we're still managing with some staff issues and supply issues? It's been a big challenge. So how do you define quality today? What is your definition of quality? I ask you all as you're listening in, what words and what concepts do you think of when you say, I know what quality is in healthcare. We read about it, we talk about it, but many of us don't have a common definition of what quality is. We often think about it as meeting the expectations of our customers, conforming to requirements such as JCI standards, making our lives better. Well, there is a a generally accepted definition of quality that we use around the globe. And it's important to note in this definition, that when we talk about quality, it applies to individuals as well as populations. There's a new focus in quality, not just about the care of the patient in the hospital or the clinic, but looking at how we can improve services for our patients who are outside of the hospital, in our community. And we also look at making sure that those practices are consistent with the best practices, the evidence-based medicine. So it's important that you think broadly about the definition of quality. And quality is complex. It has, as we know, 6 different dimensions as accepted by global definitions of quality. Safety is but one aspect of quality in healthcare. These other 5 dimensions are equally important. So I started my career before we were talking about patient safety. Patient safety wasn't a term that we even used in the 1980s. That was introduced with some important publications that came out and research that identified the risks our patients are at when they come into the healthcare setting, and some unfortunate events that happen because of what we do as a healthcare system. But as you're developing your plan around improving quality, maintaining safety, it's important that you remember all of these elements of quality. And as we dig into the concept of patient safety, I like to share this slide because it helps, again, identify the complexity of patient safety. The terminology and the classifications of patient safety have not been standardized in the literature, and that's one of the barriers. Today, we want to look at patient safety events more broadly than we did before. When you look over at the right side of your screen, many of us are familiar with the term adverse events or sentinel events, those very bad things that happen to patients. But we want to start shifting our attention in patient safety to the left side of this screen, where we look at hazardous conditions or close calls. These are things that never reach the patient. So when we come into organizations and we ask them, what are you doing around patient safety? Those organizations that are most mature in the development of their patient safety program are looking at what we call these lagging indicators. They're looking at things that are leading indicators, things that have not even reached the patient, things that indicate you may have a high-risk condition. So I ask you, in your organizations, as you're reporting patient safety events or evaluating them, are you looking at these leading indicators? Are you looking at near misses or hazardous conditions? It's important that we go upstream in patient safety and start understanding these things before they become a sentinel event. So you'll note on a couple of my slides, I've highlighted, for those of you familiar with the JCI standards, I've highlighted on several of these slides which standards or which source these definitions and this information comes from. You can use that as you go back to your organizations to understand more about each of these topics. Today, as we talk about patient safety, then we can't get away from the concept of culture. Organizational culture is so important in all that we do in healthcare quality and safety. There's a saying that says, safe culture eats strategy for lunch. Culture is even more important than your policies and your procedures and your plans, because the culture, the environment in which you work, has such an influence on the behaviors of all of your staff. And this is a really important description of the different elements of a safety culture, starting at the bottom, making sure that staff are aware of the multiple systems within an organization, and recognizing that we as humans make mistakes. We have limitations on our ability to perform, that we are not going to be perfect, and that you have an open culture around reporting, and that includes those near misses, and that you have a flexible culture as you're able to recognize those things that need to be improved, that you can be nimble and responsive, just like we've seen in many organizations during this pandemic. That just culture is so important of how we manage each other, our staff, after a mistake has happened, understanding there is a difference between acceptable and unacceptable behavior, between mistakes and things that we didn't intend to do versus those types of errors or intentional mistakes. And that we have a learning culture, that we're constantly looking at the data and the information and learning to make adjustments. So we can't talk about safety without talking about culture. And I ask you another question. Are you measuring your culture? There's a lot of tools out there that help you understand what is your culture and what are we doing about it. Once you're asking your staff about culture, how are you improving that? So here's some data to share with you. This happens to be United States data, but what we do in the United States is we offer at Joint Commission the opportunity for hospitals, and it's also available in the international community, and we analyze all the data from those really bad adverse events, the sentinel events. And this just shows you where the top most frequently reported sentinel events are in the United States from last year. Patient falls, unintended retention of foreign objects during surgical procedures, and a high risk of suicide. It's really important that we recognize we have not reached that goal of zero harm to patients in our healthcare setting. We're continuously trying to improve, and we see this around the globe. 1 out of 10 patients around the globe are still harmed in hospitals. So I ask you, have you defined what a sentinel event is in your hospital or your clinic, in your health facility? Because it's important that you define what a sentinel event is. We have a list in the JCI standards of what we include as a sentinel event, but each organization needs to know and define what is their sentinel event. And are you measuring them? And how are you evaluating those so that they don't happen again? Here's a recent publication that came out, at Joint Commission International, we gather data and information from multiple sources. It's one of the best things about this organization. We do the work for you to understand what is the evidence-based medicine, what are the best practices, what are the highest risks around the globe. And this publication was just came out, and this reflects what we've gone through in the past year with COVID-19. These are the top 10 patient safety concerns for this year. And what's really interesting is they are completely different than last year. You see things on this list that we did not anticipate a year ago. Look at number 2, emergency preparedness and response. That's one of the most important JCI standards out there. And this is one of the top concerns of organizations in the United States, but we see this around the globe. We have seen, unfortunately, all the racial and ethnic disparities in the United States, but we continue to struggle with that globally. So I ask you, what are your top 10 patient safety concerns? And what are you doing to address those? You can't move forward if you don't know where you are today. So as you try to get through this pandemic and develop strategies to improve your quality and safety program, you need to set a goal. As with any project, set your aim. What are we trying to achieve? Today, we now look at, in general, in healthcare quality and safety, 4 goals. It used to be called the triple aim, but about 5 years ago, we added one called Improving Staff Experience. This across the globe is what most of us are looking at as we try to improve our healthcare systems, improving health outcomes. And again, that's for our individual patients as well as our populations, improving that patient experience, the whole experience of as a patient passes through our healthcare systems, reducing cost. No one has endless resources, and we're really going to be struggling with this after this pandemic. And really improving staff experience, and I would make that really simple, assuring our staff are safe and healthy. We have struggled with that aim in the past year. COVID-19 has really had an impact both on the physical and mental health of our staff. So again, I ask you, where are your goals? Where are you going as you strive to improve your quality and safety program? And after you've set those goals, what do you need to get there? How are you going to reach those goals? Well, one of the first things you need to do is recognize the systems in healthcare. Systems thinking is really critical for us to be able to manage and develop a strong quality safety program. This concept and this model, often referred to as the Swiss cheese model, many of you may have seen it. It recognizes that most of our events, our incidents down at the bottom, are not due to bad staff, negligence, or misconduct of an individual. It's due to our systems, those slices of Swiss cheese, that are not perfect, that have holes in them. And when a mistake is made or a hazardous condition exists, and they slide through all those systems without being stopped, that's what leads to an incident. Each of those Swiss cheeses, those systems, can act as a defense barrier, but they have inherent weaknesses. So it's important as you're building your quality and safety program that you look at each of these systems and figure out how can we improve them, get rid of some of those holes so that we don't have accidents passing through them. This is a great structural model that I refer to a lot. It talks about systems thinking, but it helps you put it in the framework of structure, process, and outcome, because we know the structures have an influence on the processes, and those together lead to our outcomes. But this drills down even further of understanding what are the structures in healthcare that we need to develop as we build our quality and patient safety system. And you can see several of them listed here on this slide. You need to have a strong infrastructure that supports quality across the organization. And it starts at the top with your leadership. But you need to have a workforce who's trained and qualified. You need health information systems that can support it, and you need the funding. In addition to that infrastructure, you need processes that are evidence-based, that are focused on decreasing variation and finding those defects, those holes, so that you can prevent those accidents from happening. And then you need to look at your outcomes. And those outcomes happen at the patient level and at the organization level. And you need to use data. The only way we know what we're doing in quality and safety is looking at that outcome from a data perspective. So a quality and effective, strong quality management system manages quality across all structures, within all processes, at all levels of the organization, and monitors it with a host of outcome metrics. So as you're building your quality program, think about each of these buckets and how they address quality and safety. So here's a quick quiz question for us all. When you think about who has the ultimate responsibility for your quality improvement and patient safety program, is it the quality improvement director? Is it your medical director? Is it your CEO, your chief executive officer? Or is it your governing entity, like your board or the Ministry of Health? Well, I'll tell you, the ultimate responsible individual is your governing entity. It's an honor to be speaking with your Ministry of Health because you are the ultimate responsible party for leading quality and safety. I'm so impressed that you're hosting this webinar to help train all of your staff and take everyone on that journey of improving during this pandemic. As I talk about building a quality patient safety program, I talk about it as the house of quality. And I put this slide up here for you to think about these different elements. And we've talked about some of them in our structure, process, outcome picture. But this one helps me think about the framework, the quality management system that you have to build. Those are that infrastructure. Those are the things that have to be in place. In the engine room in the basement is your performance, your improvement. That's your continuous improvement cycle. And you may be using Lean Six Sigma or PDSA, but that's your engine that keeps that quality continuously moving forward. And the fuel for that engine is data. You have to use data to be able to do quality. And of course, in the middle of this is your patient, making sure that patient is safe and has the highest quality of care. If you have all of those elements in your house of quality, you will meet the JCI accreditation standards, and you can put that roof on your house. Of note, this is also the curriculum that JCI teaches in our quality course around the globe. So as you move forward in this journey, how are you going to build that house? We've talked about setting a goal. We've talked about structure, process, and outcome data that you need to define and prepare. But how are you going to build that? Well, I suggest you look at Joint Commission International Accreditation, both based on the evidence and the response during this pandemic. We know organizations that use the JCIA standards go through not just the standards, but the process of accreditation, have been able to manage through this pandemic as effectively as anyone can. As you know, we're well known throughout the globe. We've accredited in 100 different countries, and we've accredited over 1,000 different organizations. And mind you, we don't just accredit hospitals. We have 10 different programs that we provide our accreditation to. So here's another quiz question. Based on the evidence in peer-reviewed literature, accreditation is associated with which of the following? Better process improvement, process performance, sustained compliance with surgical timeouts, reduction in staff turnover rates, reduction in readmission rates to hospitals within 30 days. Well, I'm pleased to say all of those things have been shown through evidence-based studies as a benefit of accreditation, and there's many more. My point here is the accreditation process can help you build a strong quality and safety program. We have a set of standards. We come in and provide you with the expertise from our surveyors or our consultants to identify risks, help you develop critical thinking, and improve your outcome. Here are some of the top findings that we had in the year 2019. We're still collecting our 2020 data because of the disruption. And I show you this to help you identify in your own organization, where are your areas of opportunity to improve. You'll see there are several facility management and safety FMS standards that are noted. And my colleague Francine is going to share with you some great information specifically about what you can do to address some of these findings. I also want to highlight that these quality and patient safety standard 4.1, which looks at qualified professionals to analyze data, has been a top finding across the globe for years. This is where you need to put some of your efforts in developing your workforce capabilities of being able to manage the data that will help you build that house of quality. So the coronavirus has taught us a lot about many things, but it's also highlighted how accreditation can help us. Accreditation is a roadmap for you to follow that will help you develop your strengths and address your weaknesses. We've known for years that a pandemic was inevitable. Organizations that were prepared were able to adjust and flex and address some of the issues that they've been challenged with. We've introduced telemedicine, and though that's a new concept, it's been around for a long time. We exploded the use of telemedicine throughout the globe. And guess what? A lot of our JCI standards apply to telemedicine. We've identified ways of preparing staff with training of how to use PPE, how to manage, and converting and working with our communities to help screen for patients for COVID-19. And all of these lessons have taught us about some of the basic concepts, those structures and processes that we need in our organization. And many of these are supported by JCI standards. In fact, as we've talked to organizations around the globe, as we've learned from our colleagues, both accredited and non-accredited, some key themes have come out from organizations that have been able to respond to this pandemic. Preparation, strong leadership, data-driven, and resiliency. And all of these are described in JCI standards. So what does the future look like as we're getting through this pandemic? How are we also managing as we move forward? Well, it's a new era for quality. As they say, the times they are a-changing. We are in a new innovative phase throughout quality, both in healthcare and out. But there's always been innovation in healthcare. That's always been part of our science and our profession. And COVID has only accelerated this pace of change and our movement into the new era of quality. And we've shown that we can respond faster. We've never developed vaccines as fast as we have in the past year. It's usually taken years, and we've done it over the time period of months. We've made structural changes in our hospital. We've had innovative use of equipment. So we know we can innovate, and we know we can do it quickly. But unfortunately, we're a very stubborn profession. Healthcare is one of the worst industries at adopting and diffusing innovation. Hand hygiene was first recognized in 1847. Yet globally, our hand hygiene compliance rate is around 60%. And there's a study that showed it takes about 17 years for physicians to incorporate new knowledge into their practice. It is time for us to move forward and reframe what quality is. In the world of quality, there's a discussion going around about this transition from quality 3.0 to quality 4.0. It's consistent with the movement in other industries moving into the fourth industrial revolution. And it's all about the digital transformation. How we're using technology more, how we're using machine learning and advanced analytics. But there's technology as we look at quality 4.0. We need to find new ways, not just fix a broken process. And we've done that during this pandemic. We need to be more creative. We need to get away from just improving a process separately from adding technology. Technology is part of everything that we do. We need to address process improvement at the same time that we're bringing in technology. And really importantly, we need to recognize that it's not just the technical advancements that are important. It's the people. It's the people that are doing studied houses and why some are successful and why some fail. It's not the technical aspect of improvement. It's managing change. It's how we help people process through that change, how we communicate, engage them, work as a team. This concept of change management is one of the most important look at system transformation. So the evolution of quality is happening. We're in the midst of it, and we're really going to be accelerated as we move through this pandemic. We've gone through standardization, quality assurance, and quality improvement. It's still really important, and we still need to use all of these elements of quality. But we're moving to a new era called high reliability. High reliability, how are we setting that vision of zero harm, of zero infections, of zero falls? How are we changing the mindset of all of our staff, where it's not just about doing a project, fixing the waiting room time in the emergency department, but changing our culture, failure, aware of all the safety risks that occur and those hazardous conditions, those leading indicators, not waiting till there's a problem, but being aware that could be a problem and addressing them. Joint Commission has been a leader in driving high reliability in healthcare. We're all still learning how to do this. We have a ways to go, but this is the current, this is the future. This is the new normal. A recent publication from the WHO, the World Health Organization, includes high reliability systems as a strategic objective for global strategy for patient safety. So I really appreciate the opportunity to learn with you. COVID-19 has demonstrated our weaknesses and our strengths. Quality and safety are core elements of a pandemic response. And accreditation provides you that roadmap. It's an evidence-based framework that can help you manage through the pandemic and can take you into the future as we strive for that high reliable organization and zero harm. Thank you very much.
Thank you, Catherine, for a real eye-opener, insightful, inspiring presentations. We're so glad to have this presentation with you this afternoon. So before we proceed, it's going to be a panel discussion in the end of both sessions from you and also from Francine. And for now, before we proceed to Francine, I would like to give a bit of like an introductions or like a bit of sharing to the whole participants, because it's in English, so probably I can share with them a bit about what you have shared just now, and hopefully it's going to inspire them to what are they going to ask you in the Q&A sessions further. Oke, jadi Bapak-Bapak dan Ibu sekalian, teman sejawat di Kementerian Kesehatan dan juga teman sejawat di seluruh rumah sakit dan juga keperawatan, dan saya lihat tadi ada banyak manajemen rumah sakit juga dari beberapa grup. Selamat datang di acara webinar ini. Jadi dasar kenapa kita mengambil judul yang hari ini disampaikan oleh Catherine adalah kita sering organisasi rumah sakit kita sudah melakukan akreditasi. Tapi pada saat ini, begitu kita melakukan akreditasi, kita terkadang bingung mengapa sulit sekali untuk mencapai sebuah perbaikan atau mencapai sebuah standar tertentu yang kita inginkan untuk tercapai. Dan mungkin kita juga sudah merasa bahwa kita sudah melibatkan banyak pihak di dalamnya, kita juga sudah melakukan banyak hal juga untuk mencapai perubahan-perubahan tersebut. Dan tujuan dari materi yang diberikan oleh Catherine hari ini adalah ingin membantu semua rumah sakit yang ada di Indonesia yang tentunya sudah melakukan akreditasi, baik akreditasi nasional maupun akreditasi internasional, untuk melihat kira-kira ada di mana sekarang kita berada dan hal-hal apa yang akan perlu kita buat untuk kedepannya untuk melakukan perbaikan agar kita mampu mencapai tahapan-tahapan tadi yang sudah dikatakan oleh Catherine. Jadi tadi presentasi sudah dimulai dengan definisi dari mutu itu sendiri. Jadi definisi dari mutu adalah bagaimana kita mencapai sesuatu desired outcome atau hasil yang ingin kita capai baik di dalam masyarakat maupun di dalam lingkungan kita sendiri di rumah sakit, dan bagaimana orang-orang yang ada bersama kita baik di dalam komunitas maupun secara personal dapat membantu untuk mencapai tujuan standar mutu yang kita inginkan tersebut. Kira-kira seperti itu. Tadi juga sudah dibahas mengenai 6 dimensi mutu yang ada beberapa hal tadi kalau kita lihat di dalam presentasi beliau. Kemudian juga ada quality framework. Jadi apa yang harus kita persiapkan dalam quality framework kita sebagai kerangka kerja kita untuk membuat sesuatu perjalanan mutu ke depannya melalui akreditasi tentunya. Dan yang paling penting tadi sudah ditutup dengan quality 4.0, atau bahwa quality ini atau rumah sakit, dan mungkin saya rasa bukan hanya industri kesehatan tapi juga seluruh dunia pada saat ini karena Covid-19 sudah berubah tatanan. Dan pada saat sudah berubah tatanan seperti ini tentunya ada hal-hal yang harus kita persiapkan ke depan, bagaimana kita mencapai suatu standar mutu atau budaya mutu yang kita inginkan untuk tercapai di rumah sakit. Mungkin itu yang bisa saya sampaikan, mungkin ya mudah-mudahan bisa membuka wacana juga untuk ingin bertanya apa kepada Catherine nanti pada saat sudah di akhir acara atau juga di acara pertanya jawab atau Q&A sessions. Mungkin itu yang bisa saya sampaikan sementara. Kita akan lanjut ke pembicara berikutnya, yang ini juga tentunya sudah ditunggu-tunggu, karena kita tahu bahwa di dalam standar keselamatan pasien mengenai facility atau fasilitas yang kalau di dalam KARS itu disebut sebagai MFK, kalau di dalam GCI itu disebut sebagai FMS, kita banyak sekali mengalami kesulitan, terutama di dalam standar mengenai fire safety atau standar kebakaran, dan juga bagaimana standar gedung yang baik untuk facility kita. Ini semuanya akan dibahas secara umum oleh Francine Westergaard, pembicara kita kedua pada sore hari ini. Sebelum saya mulai, Francine, I would like to introduce you to all of the participants. So I'm going to read a brief CV of you. So please kindly wait. So Francine sudah bergabung di DCI sudah lama sekali. Beliau berpengalaman lebih dari 35 tahun. Beliau adalah perawat. Dan perawat ini sudah berfungsi sebagai praktisi juga, sebagai dokter, sebagai administrator juga atau bekerja di rumah sakit, dan juga sebagai bali. Beliau sudah menjadi 10 tahun sebagai konsultan DCI dan sudah menduduki berbagai posisi dalam rumah sakit dan juga di beberapa ambulatory care setting. Edukasi beliau adalah diploma nursing di daerah Chicago dan Oakland, Illinois, US. Kemudian kepada Bachelor of Science di Louis University, Illinois. Teruskan untuk Master juga di Louis University. Dan terakhir beliau mengambil Master of Business Administration dari Walden, USA. Kemudian untuk profesional afiliasi yang beliau geluti pada saat ini adalah American Organization of Nurse Executive, kemudian RPI Certified Yellow Belt, dan juga Sigma Theta Tau International Honor of Nursing. Okay, Francine, please forward with the presentation. Time and floors is yours.
Thank you very much. Thank you, Dr. Denny. I would also like today, I'd like to thank Dr. Denny for moderating our session, and I'd also like to thank the Joint Commission International Asia Pacific Office for the invitation to participate in this conference this afternoon. Happy Friday, everybody. So I have worked since 2000 because prior to that, I spent a considerable amount of time in Indonesia. So for me, it's wonderful to see familiar faces and names in the participant group. It's just delightful to be back in Indonesia. I wish we could all be together face to face. What I would like to do this afternoon is talk a little bit about facilities management and safety chapter, the FMS chapter. For some reason, okay, so this first slide is a graph. It's a tool that breaks down the facilities management chapter, and on the left side you can see the topics that are included in that chapter: leadership and planning, safety, secure, hospitals that work in accredited hospital. These topics are familiar to you. What we've done in the 7th edition is we've redrafted the FMS chapter and put it in a more logical sequence. The right side of this chart will give you the correlate. Know that you can go to FMS 8 through FMS 8.5, and you'll find all of our requirements in the manual on that particular topic. So this is a breakdown of how the facilities management chapter is now structured and organized. And I'm going to briefly talk about each of these topics. I will highlight frequently scored facilities management standards and talk a little bit about how you might be compliant with those standards and give you some tips and suggestions. So let's start with leadership and planning. So in addition to the standards manual, there is a process that is assessing your organization's compliance with the standards. At the very back of the survey process guide is a table that you should have filled out, you should have completed for your organization, and it's a table on all of your local laws and regulations. It helps you know what local regulations, what codes, and other requirements apply to your hospitals, to your facilities when the surveyors come, because the expectation is that your organization is compliant with what is required in Indonesia. And whichever is stricter, either your laws or regular standards, needs to make sure that you have implemented these requirements. They also need to ensure that you are compliant with them. And if you've had any type of inspection or audit from a local regulatory body, and there have been some findings and observations that you need to correct plans for your external reports and for those citations. So the surveyors, the JCI, so the JCI surveyors are going to look at those reports, and they want to see how your leadership team is correcting those findings from your local inspections as well. Okay, so this chapter also requires that you have a qualified individual that is overseeing the facilities management structure in your organization. What does that mean? We do not give you criteria or specifications for what qualifies an individual to be responsible for your facilities management structure. They should have appropriate training in these topics and be able to oversee and coordinate the team that's going to be making sure that your building is safe and sound. That person should have a job description that describes their qualifications and explains how they're going to coordinate production activities. So moving into risk assessment and monitoring, our standards do require that all organizations complete a risk assessment, and that risk assessment should identify any potential failures for the 8 different FMS programs that were described in that chart that I started this presentation with. We also expect that you develop, implement, train, and exercise the priority hazards and the risks from your operational plans. Dr. Leonhardt spent a considerable amount of time talking about the COVID pandemic and disaster response. Everybody across the globe has learned a great deal since the pandemic started. Those learnings into our disaster management plans. Our planning efforts also need to be inclusive of the goals to evaluate the effectiveness of your facilities management programs. So you determine what your risks are, you establish your facilities management programs, you implement them across your organization, and then you evaluate them set for yourself to make sure that your structures are safe, to make sure that your action plans have been well implemented. So your risk assessment needs to be reviewed at least annually. What many organizations do at the end of a year, sometime in fourth quarter, they review how that year has assessed their organization to see if the risks have changed. Last year is a perfect example of how our risks were adjusted numerous times throughout the year and our plans changed. And then you begin to create your plans for the subsequent year, for the next year, and then you start the cycle all over again. Several different tools that are out there. The most frequently used is the Hazard Vulnerability Analysis, the HVA. And those tools will help you identify a list of potential hazard risks. So for some of your organizations that are close to the sea, you worry about tsunamis. I've worked with some of your organizations that are very inland, hanging onto the campus in the nighttime. So it's helpful for you to categorize where your risks are and what they are based on your location. So some of the natural occurring events could be tsunamis, floods. In the Middle East, we see a lot of sandstorms. In some countries, we see hurricanes. Another category could be technologically occurring events, such as IT downtime. Many organizations over the past few years have been hacked and have had problems with their IT systems. So one of the questions that you may want to discuss is during your survey is how are you protecting the data for your patients? Another problem could be power outages, water fed, human-caused events such as epidemics, mass casualties, terrorisms. So we encourage you to use a special form to identify your potential risks, your potential epidemics, and then apply them to the action plan that is specific to your organization. I'm going to move into safety. So when we talk about safety, we're talking about a safe physical facility. And you should be doing that through a number of different inspections and have plans in place in order to reduce your risks. So you want to have a good safety program. And my visuals here include some examples of, for example, emergency eye wash stations, or having mechanisms in place in which to secure safety vest on, and they have a checklist. Maybe they're visiting a construction site. We'll talk a little bit about that some more when we get to that topic. Okay. So your safety program refers to you making sure that your building, that your property, medical and information technology, your equipment, and your systems themselves, to your staff and to the visitors. So you want to make sure that your environment is safe for those individuals that are in your hospitals. And you do that by preventing and planning. Those two components are essential to creating a safe and supportive patient care facility. So you want to have effective planning in place, and that planning should require that the hospital and your team be aware of all the risks that are present in the facility, as I talked about with your risk assessment. So here are some examples of safety risks, and here are some ways in which you can reduce those risks and some risk mitigation strategies. So some of the risks include needle sticks, back injuries to your staff, or maybe medical gas storage, slips and falls, construction. There's always construction going on in our healthcare facilities, and they pose huge risks to everybody that's inside. That's a whole presentation in itself. Hazardous materials are a risk, and one of the most frequently scored problems during surveys, infectious disease, and that has been with pandemic, that you must comply with your ventilation system, your HVAC system, and then any other hazards that are present and specific to your organization. So how do you minimize those risks? How do you mitigate those risks? You do that by providing a lot of staff training, reinforcing that training, policies and procedures in place. Those policies and procedures should tell you who should do what, when should they do it, how should they do it, and if they are required to document, where and how do they document. Another risk mitigation strategy is substitution. We learned about that when our supply chains were disrupted during the pandemic, and then we had to replace products with different sources. Inspections and audits are actually our friends, and they help keep us compliant. Personal protective equipment is a big risk mitigation factor, and as Dr. Kathy said, it's something that we've learned to value over the recent decades. A safe health design is a risk mitigation. It can help us minimize the risk of falls. It can help us improve the flow of our patient. It's very, very helpful to us. A good, strong ventilation system is helpful. As you all know, we need to be careful because there are certain molds and fungus that really grow well in healthcare settings, and so we need to make sure that we are minimizing the risk of those spreading. We have problems, and we need to make sure that we're complying with regulatory bodies. Now I'm going to talk about security, because security is different than safety. Security is protecting your organization's property. It's protecting your patients and their property. It's protecting the patient's family members, the visitors, our vendors. Security here in the that I have. We have an infant alarm system, an infant abduction prevention photograph here with an infant that has a security tag on their foot. You see the badge of a security guard. You see a closed circuit television camera, and you see a hospital of tools that we use to provide security within our healthcare organizations. Again, here are some examples of safety risks. I'm sorry, I seem to be going backwards. Here are some examples of security risks and security mitigation. So examples of security often ban a patient who might be compromised. Workplace violence that can be problematic, where people feel intimidated or physically violated. Other security risks could be door locks that might not be working correctly. Unidentified vendors walking through our organizations, infant abductions, or VIPs. Anytime there's that security risk. We also are very concerned about data security breaches or terrorism. Patients or employees bringing weapons onto the hospital campus, and then our IT security systems. How do we mitigate some of those risks? Well, we can do that with a number of different things. We can have employee identification badges, closed circuit teeth that we use as long as we continue to protect the privacy and the integrity for our patients. Making sure our door locks are secure and working appropriately, and particularly when you think about fire doors that protect in between different locations in the hospital. Key card access using our security into secured protected locations in our healthcare organizations. Performing security rounds are very helpful. And then again, having strong policies and procedures in place. Limiting access to data to the people that need to know the information, and make sure that they're only their passwords with others, to make sure that everybody is using their own password in order to keep that data safe and secure. And then providing a lot of training and education, and then drills, and exercises to help us or not our staff. I'm going to move into hazardous material and waste, and you can see there's a red exclamation point in the corner, and that is because this is one of the most frequently scored standards across the globe. Your hospital is expected to have a program in place for the inventory, handling, storage, and use of hazardous materials and waste. Inventory and handling questions that we get very frequently is, how do we inventory all of the hazardous materials that are within our organization? And so what we expect you to do is to know which hazardous materials and which hazardous waste items are in the department, and then simply have a maximum allowed quantity exceed this much. And so why is this important? This is important because it will help you with your risk mitigation. if you know where you have excessive contents of hazardous materials or flammable materials, you should incorporate this into your fire safety response. If you know the ability of having large amounts of flammable materials in a certain department, you're going to want to make sure that your inventory is capped at a certain amount, that you have the appropriate storage for those chemicals and things like that. And then handling. Handling is frequently scored because many organizations don't have the appropriate spills kits available. So here, what you can see are some examples, again, of an hazardous material identification processes. Safety data sheet information is very important to have available so that when something does spill or when staff is handling something, they know how to do it, they can do it properly, they have the appropriate personal protective equipment, and they have the right quantities of the necessary supply or anything that will occur. So this is a frequently scored standard, and there's some tips on how to manage that. So your hazardous material program should include identifying and controlling the hazardous materials and waste throughout your facility. There are some different types of hazardous materials and waste. It could be infectious, it could be pharmaceutical things, for example, chemotherapeutics. There could be chemicals, heavy metals, pressurized containers like our medical gas containers, our sharps, our genotoxic and our cytotoxic materials, and then of course radioactive. So make sure that you have everything classified, make sure safety data sheets that I talked about, and that they have instructions and training on how to control their hazardous materials and waste throughout the facility. WHO has a nice categorization of waste, and they break it down into these different categories. This is downloadable at the website that I have referenced here at the bottom of the slide. Here is an example of a tool that you can use when you're inventorying some of the types of waste. You can also change out the word waste and put in types of hazardous materials in here. And then you can have weights, volumes, any notes that you want to include with this. So here's an example of a simple tool that you can have in place, keep your organization safer, and can also help you be compliant with the Joint Commission International Standards. Here's an data sheets available, information for employees. Some organizations use binders like this, and they are in a very bright color, so staff can identify them quickly when they need them, because these are usually pretty high stress emergent situations of a safety data sheet. Other organizations have all of this information available online. So again,
Francine, are you there? Hello? Hi, Francine. Oh, okay. Hi, Francine.
Jeannie, I can reach out to her by WhatsApp.
Okay. Oke. Sambil menunggu Francine bergabung kembali bersama kita, terima kasih banyak. Saya ingin mengucapkan untuk beberapa pertanyaan yang sudah masuk. Dan juga untuk antusiasmenya terhadap acara ini, jadi hari ini di Zoom kita ada 300 partisipan, dan juga di YouTube sudah lebih dari 610 partisipan yang bergabung bersama kita. Jadi sekali lagi terima kasih untuk antusiasmenya yang luar biasa dan tentunya mendengarkan beberapa materi yang sangat menarik dan sangat inspiring buat kita, menjadi inspirasi kita untuk bagaimana mewujudkan mutu dan keselamatan pasien di rumah sakit. Saya share sedikit mungkin tadi apa yang sudah disampaikan oleh Francine sebelumnya. Jadi yang paling penting dari mengenai MFK atau Facility Management ini adalah yang pertama kita memiliki orang yang memang betul-betul qualified atau kompeten di bidangnya. Itu yang tadi beliau sampaikan. Kemudian juga ini masih di umum ya, jadi belum sampai kepada tadi mengenai penanganan kebakaran, tadi kita belum sampai, jadi baru sampai beberapa bagian dari materi MFK. Jadi tadi beliau sampaikan beberapa hal yang terpenting, selain juga masalah orang yang bertanggung jawab terhadap standar MFK ini, juga penanganan-penanganan yang dilakukan juga oleh orang-orang yang memang semuanya paham terhadap standar ini.
Hello,
Jadi,
I'm back.
Okay, you're back. Yay.
I don't know what happened, and my apologies, Denny.
It's everywhere in the world. So, okay, let's move on.
Where did it get disconnected?
Yeah. So, please share your screen and continues. Thank you.
Francine, I think you're on SDS, yeah. Okay, perfect, thank you. So can everybody hear me?
Yeah, we can hear you well.
Okay. All right, so safety data sheets. All staff should have access to these. It's up to you to decide whether you keep them in bright colored binders or whether you have them stored on your IT system. We really would like to emphasize that it's important to share this information with the staff and then drill it frequently so you can determine whether or not staff knows how to respond during an emergent situation. Next, I'm going to move into fire safety. So your hospital needs to establish and implement a program for prevention, early detection, abatement, and safe exit from the facility in response to fires and non-fire emergencies, for example, smoke emergencies. We do require that you follow national codes. If you don't have national codes, you have to select which fire safety code you're going to use. And you can see here examples of sprinkler systems and emergency exit signage. There is an appendix at the back of the FMS chapter that contains examples of interim measures for you and your healthcare organization to use during fire events or smoke events. So please, I encourage you to go through that appendix. I'm not going to go through all the suggestions and recommendations from it, but it is an extremely helpful tool. So we encourage you to go into that appendix. Please be aware that it's there and use that valuable information that's included in the appendix. Assessment begins with knowing your fire code. As I said, Joint Commission International doesn't specify which code you need to use. Your local codes will always take precedent. We understand the codes aren't perfect, but we do want you to be as comprehensive as possible and focus on the intent of the code. We encourage you to document any variants that might be occurring and then work with your local authorities when you are designing or redesigning your healthcare facilities. So here's some examples of some fire safety codes that you might consider. Here's our exclamation point. That means we are going to be talking about a frequently scored standard. So what you need to do is test your fire safety program. are required to participate in at least one fire and smoke safety program test per year. What's highlighted here in yellow is what is frequently scored. Your staff need to be able to demonstrate how to bring the patients to safety. So again, we encourage fire drills. We encourage you to use tools. For example, tools are RACE and PASS. PASS is a acronym to use with a fire extinguisher. You pull, you aim, you squeeze, and you sweep it at the base of the fire. And then perform evacuation drills. Please keep in mind, if you have any construction that is underway in your healthcare organization, please evaluate altered during the construction process. By this I mean, if your fire evacuation route is now in the construction zone, you will have to change that and you'll have to explain that to the staff. And we encourage you to drill that process with them. Excuse me. Next, I'm going to move into the topic of medical equipment, that your medical equipment is available for use and that it's functioning properly. Examples of medical equipment could be your infusion pumps, it could be your patient monitors, it could be your blood warmers, as Dr. Kathy mentioned, your ventilators. So all of your medical equipment is valuable resources for your organization. So you want to have a good repair program, and you want to make sure your staff understands how to use your medical equipment appropriately, including the alarm systems, because we all know of that phenomena that's called alarm fatigue. That's where staff has heard the alarms going off for such long periods of time that they become desensitized to the medical equipment alarms. So make sure that your staff is in tuned and that they're using the alarms correctly, that they have the parameters set appropriately for the patients, and that they are responding to those alarms in the appropriate manner. Here is an example of medical equipment inventory, because we do require that you inventory all of your medical equipment. So what's the name of the equipment? What's the unique identifier that has been assigned to that piece of equipment? What other pertinent information is necessary for that piece of equipment? This could include leased equipment. For example, if you have contracted services for dialysis and your dialysis vendor brings dialysis machines to your organization, that would be an example of a vendor bringing in equipment. Another piece of equipment that could possibly be leased, and we are focusing on quite a bit now, could be laser equipment. So think about your leased equipment. It includes any contracted maintenance agreements that you have with outside organizations. For example, and I am not endorsing a company, I am just providing this as an example. For example, many organizations have contracts with companies like GE to come in and do maintenance on their large radiology or laboratory equipment. So make sure your inventory information includes any contracted maintenance. Anything that is necessary for periodic maintenance, PM, periodic maintenance, and then the importance of insurance, protecting your equipment with insurance. Make sure that you have a process in place and policies and procedures that describe your recall system. Your recall system should be in place for monitoring and acting on medical equipment hazard notices, recalls, any incidents that you have to report, or incidents that have been reported by other organizations that you are informed of, any problems or failures that you have. For example, Dr. Leonhardt talked about adverse events. It's not uncommon for adverse events to include sometimes equipment for a medication adverse event, a medication that might have been infused on a syringe pump or another piece of equipment. So keep that in mind. When your laws and regulations require that you report any of these deaths, serious injuries, or illnesses that are the result of medical equipment, make sure that you have a process in place for reporting that appropriately. And make sure that your program addresses the use of any medical equipment with a reported problem or a failure that is subjected to a hazard notice or is under recall by the manufacturer. Please keep in mind that when you're looking at your medical equipment, to include your point of care testing, how is that being calibrated, for example, your preventive maintenance program evaluation and effectiveness, work order management system. When we talk about the work order management system, we talk about the staff has identified that a piece of equipment isn't functioning properly. What is the work order management process for that? And then please review your processes for determining the need of additional procurement or commissioning of new equipment, staff training and education, maintenance and monitoring, inspection, your processes for repair, and then eventually decommissioning your equipment as well. And then how do you track your equipment throughout the organization in case there is a recall on that piece of equipment? The next topic that I'm going to move into is utility systems. Your hospital needs to establish and implement a program to ensure that all of your utility systems operate effectively and efficiently. Here are some examples of utility systems: your emergency power, your electrical distribution, communications, refrigeration, your vacuum system, your piped medical gas, boilers, steam, plumbing. So all of these are examples of your various utility systems. When you see the depth and the complexity of the facilities management chapter, it helps you sincerely appreciate why the JCI standards include facilities management. That's one of the things that make our standards really unique. We appreciate everything that it takes to provide support to the healthcare workers and the patients that are receiving care in our facilities. So you need to have an inventory and a distribution map of your utility systems, the components, and how they're distributed throughout your organization. There are two unique and separate requirements. You have to have, number one, the inventory. So you define your utility components and then your necessary preventative maintenance program, and then you map all of that out. In new construction, it should be part of the as-built handover. So when your architects and your construction team is building you a new building, they should hand all of this information over to you. For an existing building, you need to complete a risk assessment to determine where your priorities are. And then you need to have this map, the distribution map, because it's essential for your emergency response, including any shut-off processes that would occur during an emergency situation. So medical gas and things like that. Here are types of systems that need labeling: your medical gas system, your electrical panels, and your plumbing lines. So keep this in mind. Those systems should be labeled and identified for your staff. Now we're going to talk about emergency and disaster management. I did mention that one of the tools that is frequently used is the Hazard Vulnerability Analysis tool. If you start with that type of tool, you identify all the different potential emergencies and disasters that could be problematic for your organization. You prioritize those emergencies and disasters and create a plan. You test that plan, you evaluate that plan, and then you provide feedback to everybody that's involved. Every year, Joint Commission brings together its leadership team, and last year in 2020, before the pandemic, we had our annual plan. We were all face to face, and we had presenters from the folks that were in Orlando, Florida, and responded to the nightclub shooting that occurred. So that terrorist event. And they told us the thing that helped them be most successful during that event was the fact that they tested and tested and tested their disaster management system over and over again beforehand. As you know, they're all in Orlando. They're all real close to Walt Disney World. So they had actually planned and tested an event in their hospital, and they anticipated really a lot more children. But what actually happened in this event is they pulled people from the pediatric hospital over to the adult hospital. It was a Saturday morning, so what they did was they minimized and altered their surgical schedule immediately so that they could handle all of the disaster patients that came in. And it was just really impressive to learn how they responded to this. But I think the point that really impressed me the most was that they emphasized testing and drills as being part of their success plan. Your hospital should have an incident command system. Here is an example of a guidebook. This book is available if you go online and you put in Hospital Incident Command System in a search engine. You should have access to this. It's a very helpful resource. It has lots and lots of tools in it for disaster management. Here's some of the topics that happen to be inside this Hospital Incident Command System guidebook. So you can see it. It'll help you with staffing, emergency credentialing, patient management, fatality management, logistics. So, this is a topic that is hot right now because of the pandemic. Here are some tools that you might consider using. You've heard me emphasize testing. What should you do when you're testing? It's an organizational learning opportunity. It's impacted most strongly through drills, exercises, and simulations. Your testing should focus on the objectives of your plans. So what are your most likely events? What's the probability of them happening? What are the most potentially harmful events? What's the magnitude, the size of them? How vulnerable is your response? You should be testing how well prepared you are. And then you should be looking at the goals of your management of the program. How are you mitigating those risks? So prior practice of event management, you should be focusing on receiving the victims and deploying immediate resources. Current practice is to test for extended operations at large scale and large scale events. So I mentioned that I'm doing a lot of work in Europe recently when the airport in Belgium blew up and then the train stations surrounding in the city started to blow up. They learned a lot. They have a centralized command system that distributes victims throughout the city, and they were relying heavily on that. What they weren't expecting were the walk-in patients that were being carried up from the subways and brought into the emergency departments, because those patients weren't accounted for in the distribution, the central distribution center. So every organization learns from the events, and it's best to test your system so that you can be best prepared. Now I'm going to move into construction and renovation. Again, red exclamation point means that this is a frequently scored standard, and the topic that is frequently scored in construction and renovation is the pre-construction risk assessment. Make sure that you're doing that. We do have a really nice publication on planning, designing, and construction that is available on our website. And you can see here a list of the framework of the things that we encourage you to consider when you are designing and planning for either remodeling your healthcare organization or building a new one. There are some tools and resources available on our website. Things to keep in mind during construction. One of them is noise reduction. Please remember that patients are healing, and work with your construction teams to reduce noise and vibration. These interventions should be in place during your construction program. Always, always, always be aware of infection control during construction. We know that there are certain organisms that are frequently problematic during construction. For example, aspergillus is a fungus that comes out and gets into our ventilation system. And once you have aspergillus in your organization, it's very, very difficult to keep that under control. So make sure you're protecting your ventilation from dust. Make sure you're keeping your areas free from debris and food waste. Make sure that your construction employees have somewhere to eat so that they're not actually eating their food in the construction area. That's very dangerous for them. And then critical systems to consider during construction are your electrical power, not only your commercial, but your emergency power, your backup generator, because there have been times noted where the commercial electrical power has been accidentally disrupted during construction. A digging machine, a backhoe might accidentally cut the power, so make sure that you have backup with a generator available. Make sure that you have extra water resources available, sanitation. Make sure that your telecom, your data systems are backed up, and that you have secondary plans in place. Same thing for medical gas, HVAC, and then any fuel that you might need during construction projects. And then finally, the last topic that I want to concentrate on is education, staff training and education. We need to make sure that we're providing a lot of staff training and that we're doing it frequently and that we're reinforcing that training over and over again. It's not enough to hold one training session. You need to reinforce that training over and over again, and then make sure that your staff understood the training the way you intended it for them to hear it. So we do require annual training and testing in each of your facilities management programs. That training should be for your staff, for your vendors, for your contract workers, any volunteers. If you are an academic medical center or a teaching hospital, it should include your students, any trainees, and others that might be present in your organization. So think about fire training, think about work safety training, security training, and disaster management training. All of this is really essential. And with that, I thank you again, and I'm going to turn it back over to Dr. Dinny.
Thank you, Francine, for a very good presentations and also inspiring again. Sebelum kita mulai ke pertanyaan, mungkin para teman sejawat dan yang ada di Zoom terutama tahu ya kalau kita punya fitur yang disebut sebagai reaction. Ya, jadi kalau kita lihat di Zoom itu sebelah kanan bawah ya, boleh nggak kasih reaksi siapa yang merasa bahwa standar manajemen fasilitas dan keselamatan itu sulit banget. Mungkin bisa kasih reaction coba. Siapa yang bilang begitu? Saya mau tahu nih, ada berapa orang yang menyatakan bahwa standar manajemen fasilitas keselamatan itu sulit sekali. So Francine and Catherine, I would like to know from the participants who thinks that this FMS standard is very hard to achieve. So they are raising hands now, so we can see so many people's raising hands. I think
our FMS chapter is It is one of the most challenging chapters, but it is also one of the most important chapters because having a safe
Soalnya
and secure
302.
facility is really essential. And there's a lot of
Yang
work
ujung
that
sebelah
goes in.
sini sama berapa tuh? 302 kan ya? 301.
Mohon di-mute.
There's a lot of work that goes into making sure that your building is safe and secure. But that work is important, and it really is very, very beneficial for your healthcare organizations. Now, having spent a lot of time in Indonesia, I know that there are certain challenges that you have. For example, you have your beautiful heritage buildings, and those buildings are wooden, and those wooden buildings can be a challenge for fire safety. And what some of your organizations have done is they've repurposed those buildings. They've moved patient care out of those buildings and changed the use of that building, the purpose of that building for more administrative purposes, more historical purposes. So there are ways in which you can become compliant and be successful, not only with JCI, but to have a safer environment for yourselves and your patients as well.
Ya, jadi saya coba terjemahkan dari Francine. Kadang di Indonesia itu, terutama karena beliau sudah sering berkunjung ke Indonesia, banyak sekali bangunan bersejarah, terutama di rumah sakit umum yang besar-besar ya, yang mungkin sudah joint commission. Nah, tentunya itu menjadi salah satu tantangan bagaimana bangunan bersejarah tadi tidak berbahaya atau memiliki manajemen keselamatan yang baik. Ya, biasanya kan bangunannya sudah tua, jadi gimana caranya supaya bisa memiliki standar fasilitas yang baik juga untuk keselamatan bagi pasien dan pengunjung. Tadi itu yang dijelaskan oleh Francine. Okay, I have first questions. Actually, this is a very good questions. So why? I think this is for Francine. Why FMS is the #1 findings in JCI accreditations, as you said in the presentation? So ada yang bertanya, someone from the audience asking you that. Is there any other answers that you could provide besides everything? Yes, please.
So one of the reasons why the FMS standards are so challenging is because, well, there's many different reasons. Just like any time that we're digging into the root causes, part of it is staff training and education. We provide training and education once, and we think that's sufficient, when really training is ongoing and it needs to be reinforced. And staff, we need to make sure they understood what we're training them to know. Staff that have worked in the organization for a long period of time may not have had the same training as somebody that's new to an organization. Many times when we're doing tracers and we're tracing somebody that's been recently hired and have recently gone through orientation, it's very easy. They know all the answers. And when we talk to somebody that's been in the organization for an extended period of time, they're a very valuable employee because they have a lot of knowledge and a lot of history with the organization, but their training might not have been up to date. And so they have a different understanding of what should occur. Other reasons why facilities management can be so challenging is because things are changing throughout our healthcare organizations all the time. The list of hazardous materials and waste, that standard and those expectations came out to help us understand how we should plan. As I mentioned, the example of high quantities of corrosive materials or high quantities of flammable materials. Once the organization has an inventory and an understanding of where these quantities are stored and used,
it helps you with your plans. It helps you make sure that you have the right spill kits with the right supplies in the right locations. It helps you when you're doing your own purchasing and your own inventory. So those old containers that have been in a department for sometimes decades get moved out and disposed of properly. So this chapter can be very challenging, but once you start to work at it, it really brings you a safer organization. And so what we encourage you to do, when you go back to that first slide that breaks it down into the different topics, we encourage you to put together teams for each of those topics. And those teams can work together, but they focus on each of those topics that they're assigned to. And that way, by breaking it down and assigning teams to this, they're able to address each of these different topics piece by piece. So it isn't so overwhelming to the organization any longer. So when you break it down and you have an action plan in place, it makes it manageable.
Okay, thank you, Francine. So I'll try to translate to everyone first. So jadi yang paling sering kenapa MFK itu menjadi standar yang sangat sulit dicapai bagi kita semua adalah mengenai trainingnya. Jadi trainingnya itu kalau yang sesuai diminta dengan standar kan setiap tahun harus diperbaharui. Kemudian kadang ada orang yang tadi mungkin ada karyawan baru yang bergabung di tengah-tengah sehingga belum sempat dilakukan training terhadap mereka. Juga kalau misalnya melibatkan begitu banyak orang gitu ya kayak dokter dan semuanya itu kan juga sulit sekali untuk membuat orang semuanya bisa terlibat dalam training tersebut. Dan ini juga menjadi sesuatu persyaratan yang sebenarnya menyebabkan FMS atau MFK tadi itu bisa tercapai bahwa semua orang sebenarnya kompeten di bidangnya. Nah, untuk mencapai kompetensi itu tentunya tidak harus sekali trainingnya, tapi berkali-kali, dan berkali-kali itu ya tadi kadang-kadang ada orang yang sekali udah ngerti, tapi diterangin juga ada orang berkali-kali diterangin tetap aja nggak ngerti juga ya. Mbak Evi udah senyum-senyum deh dia, Ibu MC kita. Jadi ya memang begitu, kadang-kadang jadi komite mutu di rumah sakit tuh harus lapang dada dan lapang hati seluas samudra ya, jadi jangan bosan-bosan untuk memberikan training kepada teman-teman karena mutu itu tanggung jawab kita semua ya, bukan hanya satu atau dua orang. Okay, so next, this is a continuation questions for you, Francine. So how are we going to conduct any drills or exercise during this COVID-19 pandemic? Because we know that we're preventing from any mass gathering and things like that. So how should we provide any drills or exercises, especially for the FMS chapters? Please.
So some things that you can do, so there's several different things that you can do. So you can actually use the pandemic as a real life situation and go back and evaluate your disaster response to the pandemic. That's one example. Tabletop exercises. I did see in the chat that somebody put the suggestion of tabletop exercises. Yes, we would encourage you to use tabletop exercises as one tool, but keep in mind that tabletop exercises are not fully comprehensive. They are a good exercise if you want to minimize exposure and keep your crowd control low. But as soon as you're able to get everybody vaccinated and the pandemic has begun to subside, we encourage you to get back into those real drills and actually move the staff through the exercises, because visualizing it and having the staff actually perform those tasks is where we learn the most. And then sharing information with each other. What's really wonderful is you're a large group of organization. You have a blend of some organizations that are already JCI accredited. Those that are not can learn some of the processes that have been put in place by those that are JCI accredited. And then, of course, keep it simple and keep it safe.
Okay. So again, thank you for the questions. This is the question for both JCI accredited organizations from Awal Bros Batam Hospital and also from Rumah Sakit Premier Jatinegara. So they're both are JCI accredited hospitals. So you're advising to use a tabletop exercise for this drills. Okay.
Yes, that's acceptable.
That's acceptable. Oke, untuk yang bertanya mungkin silahkan bisa direspon kalau kira-kira masih kurang terjawab. And again, this is also the continuation for you, Francine. I think this FMS is a very struggling point for everyone. So how do you build the awareness for everyone that this drill or exercise of sense of crisis during this pandemic or any disaster preparedness that we need to provide is, being everyone is aware of that this is a crisis that we need to be we need to be competent and we need to be fully available if there's something that we need to do or something like that. So what should we do to build the awareness?
So there's a number of different ways in which you can build awareness. Number one, you could use newsletters and share the results with your organization through newsletters. Another method that you could use is to have Zoom calls like this and invite appropriate staff that are interested in learning more to these types of calls. Email blasts are another tool that you could use for information to the staff. Posters that are available for visual tools throughout the organizations. Of course, posters that can be, that are laminated and can be wiped down in the lobbies, in the elevators, any type of communication method that will that has proven to be effective. I know in your area there's a lot of use of WhatsApp group chats and things like that. So any method that you find to be effective in communicating with everybody, all of them, use all of them, because different people from different generations like to receive information in different ways. So make sure that you're covering as many of those methods as possible.
Okay, thank you, Francine. So that's the question from the YouTube. Okay, so we are going to move to Catherine for another questions. So the first will be the shifting from quality 3.0 to 4.0. So what we need to prepare for this in the near future.
So we are all in this transition period as we're moving into the more advanced, if you will, skills of data analytics and machine learning. And again, I'm just getting a little feedback, want to make sure I am coming across. So as we go through this transition, we need to be, first of all, evaluating what are the qualifications and competencies of our staff right now. And I specifically focus around the quality department staff. So understanding what are their skills, what's their knowledge, and Francine talks a lot about training, and just to add to that, it's training and competencies. So as she talks about drills, we would use the same type of thing, and we talk about a qualified quality professional. What can they do? Not just what did they learn, their knowledge, but what can they do? And that really applies to the skills around data analytics, the skills around change management, the skills around process improvement, and really the skills around leadership. A healthcare quality professional is a leader. And as we move into this quality 4.0, it's a transition for all industries, but healthcare in particular. We've not done a great job with incorporating our technology into a seamless workflow, right? We've thrown in an electronic medical record, or we've thrown in some high-tech equipment, but we haven't had a smooth transition unlike other industries that have done a much better job of it. So that moving into quality 4.0, I think is a lot of it is making sure you keep up with what is the needs of your organization, and then make sure you have those qualified staff. I can't emphasize enough around the data analytics and the maturity that the machines and the technology provides us. It's amazing. We're actually doing this within our own organization at Joint Commission. We're using machine learning to help us with our survey process to understand better where the opportunities are within organization, to have some consistency and standardization around our survey process. And all of this is part of today's digital transformation. I work with an organization that provides the internationally recognized certification for healthcare quality professionals, CPHQ. Some of you may be familiar with that. We work with that organization, and they recently identified that there are about 500 skill-based competencies for a healthcare quality professional. I think the future of healthcare quality is also bringing in a recognition of the role of those of us who have the skill set and the abilities to move this effort forward. We're not there with quality and safety. We need people with those skills and the competencies to do that. So my recommendation is make sure you're aware of what the needs are in your organization for qualified individuals. Obtain that training and develop those skills. We are all continuous learners, right? That's part of being in healthcare. You can never sit back and say, I'm done learning. And reach out and find ways that you can incorporate some of the digital technology. And it may not be a place that you think, oh, I'm going to go ask another nurse or a doctor to join the quality team. You may start looking in different areas. We employ in healthcare now human factors engineers. We're using human factors engineers in a lot of the work that we do. We saw evidence of that through this pandemic with the use of the plexiglass separators, with telemedicine. We incorporate these experts, these human factors engineers, to adjust the environment so that it works for us as people. We also are using data analysts much more. So you may find, I've worked with an organization in their quality department, they didn't have anyone who was really good with data analytics, but in their finance department, they did. And I said, great, ask that person to come in and help you with your data analytics. If you don't have the skills, there may be someone within your organization who does.
Thank you, Catherine. So I'm going to translate it first. Jadi tadi yang bertanya untuk Francine mengenai bagaimana cara membuat kesadaran bagi semua staf untuk memahami bahwa MFK itu satu standar yang sulit gitu ya. Kalau menurut Francine adalah gunakan semua cara komunikasi yang dapat digunakan. Jadi karena tidak semua orang dapat, misalnya gini, nggak semua orang senang dengan WhatsApp gitu ya. Kayak kita di grup kan ada juga WhatsApp grup yang kita kadang-kadang jarang baca. Jadi mungkin kalau WhatsApp harus personal. Kemudian email, kemudian juga mungkin kita bisa berkomunikasi secara langsung. Jadi pastikan bahwa informasi mengenai MFK itu dapat diterima secara langsung oleh yang bersangkutan dengan cara yang sesuai atau mungkin lebih diminati sesuai dengan usia. Tadi Francine menjelaskan mengenai usia. Karena ternyata kan di rumah sakit beda-beda ya, ada dokter yang udah senior banget, gitu, nanti bisanya SMS, nggak bisa WA misalnya gitu. Jadi ya itu juga harus kita akomodasi. Kemampuan-kemampuan seperti itu. Jadi tadi ya, jadi tim Mutu memang harus lapang dada, besar hati, seluas samudra, karena memang pekerjaan kita sangat berat. Kemudian menjawab pertanyaan tadi mengenai kita bergeser dengan adanya pandemik ini dari healthcare 3.0 menjadi healthcare 4.0 ya. Apa sih yang harus kita persiapkan? Jadi kalau menurut Catherine, yang pertama adalah yang paling penting dalam hal ini adalah data management. Karena pada saat situasi seperti ini data sangat penting. Benar juga ya, data itu kan kayak gini, hari ini jumlah COVID berapa sih gitu kan, itu pasti semua orang pengen tahu misalnya. Jadi data management, kemudian performance management, bagaimana kita mengukur keberhasilan, Dan juga leadership, bagaimana kepemimpinan dalam suatu rumah sakit dapat berubah mengikuti perubahan yang terjadi dalam paradigma karena pandemik ini. Dan semua perubahan tadi ya, baik untuk data management, kemudian performance management, dan juga untuk leadership tadi, itu bisa dicapai dengan dua hal menurut Catherine. Yang pertama adalah digital transformasi. Jadi memang suka atau tidak suka, sepertinya setelah pandemi ini kita memang harus punya suatu platform digital yang membuat kita bisa berkomunikasi kepada siapapun, baik kepada orang rumah sakit maupun kepada pasien kita. Ya, jadi kayaknya masalah digitalisasi ini sesuatu yang tidak bisa terelakkan, dan saya yakin ini sangat kita rasakan. Saya sendiri sebagai insan perumah sakitan sangat merasakan bahwa memang digitalisasi ini udah tidak bisa kita mundur-mundurkan lagi gitu. Nggak ada waktu untuk tidak berubah menggunakan digital. Dari mulai pendaftaran, bayar, kemudian komplain juga mungkin harus sudah digital gitu ya besok, seperti itu. Dan yang kedua, selain digital transformasi adalah ciptakan sebanyak-banyaknya orang yang berkompeten di bidangnya. Jadi dengan kita berkompeten di bidangnya, dan terkadang bidang-bidang itu adalah bidang-bidang baru tadi menurut Catherine ya, seperti sekarang itu di beberapa rumah sakit di dunia punya yang disebut sebagai human factor engineer. Jadi insinyur untuk khusus manusia gitu ya. Mungkin ini juga saya juga baru dengar ini ada human factor engineer gitu. Tapi ciptakanlah kompetensi-kompetensi yang banyak di rumah sakit yang memang kedepannya akan sangat membantu atau mensupport kita untuk kondisi pandemik ini. Karena ternyata pandemik ini memerlukan banyak support yang selama ini mungkin kita belum sadari. Gitu, selama ini kita nggak pernah punya disaster preparedness yang harus benar-benar jalan gitu ya. Tapi kemarin kita semua dipaksa untuk belajar tentang disaster preparedness, dan memang betul sekali kalau di chapter MFK ini, kalau orang Jawa bilang itu kalau udah kejadian itu baru terasa gitu. Sama seperti kebakaran. Kebakaran itu kalau rumah sakit ya amit-amit ya, tapi untuk orang yang sudah pernah mengalami kebakaran dalam hidupnya, itu pasti paham mengapa satu fire safety itu menjadi penting. Tapi kalau dia belum pernah ngalami itu memang biasanya santai gitu ya, ntar lah nggak apa-apa gitu. Jadi memang kita sendiri, saya sendiri dalam pengalaman saya mengalami itu. Jadi saya udah pernah ngalami kebakaran, saya pernah ngalamin gempa bumi. Nah pada saat itu ternyata kita memerlukan pelatihan untuk bagaimana kita menolong orang lain selama gempa bumi tersebut berlangsung. Ya, karena kita adalah negara kepulauan. Ya. Sebelum saya mulai ke pertanyaan selanjutnya, Pak Kuncoro Adipuryanto, Ketua Persi, ingin menyapa semua teman sejawat yang ada di sini. Beliau tadi sempat masuk, tapi karena ada kesibukan lain, jadi sepertinya live group, jadi ingin menyapa dari Persi kepada semua teman-teman yang ada di sini. Selamat mengikuti webinar, kata beliau. Ya, salam dari Pak Kuncoro. Okay, so best regards from the Indonesian Hospital Association for Francine and all the team, for Catherine also, the head of the Indonesian Hospital Association. Just actually he joined this webinar for a while, and then because of one thing he needs to leave early. So kind regards for everyone here. Okay, so we're going to move to another questions. We have a lot of questions actually, so no problems. Okay, so what is your general, I think this is for both speakers, for Catherine and also for Francine. So during this COVID pandemic, we know that it's very hard for us to maintain the quality and safety level in the hospital. So how do you have any suggestions on how are you going to implement this in the hospital? Please, maybe Catherine first or Francine first, whoever wants to go first.
I'll take a stab, Francine, and then have you join in. The answer is yes. We are really struggling globally with managing during this pandemic. There's been it's been all hands on deck, and it's really been a process of prioritizing. As a quality professional, that is a tool we do on a regular basis. So though we've had to prioritize with even limited time, limited resources, limited capacity to take care of our patients, this is something we do on a daily basis. So though I talk about the pandemic has identified and kind of emphasized our strengths and our weaknesses, every story I hear and every situation I hear, I can think of a quality tool. I can think of a JCI standard that applies. So in this situation where, oh my gosh, we're overwhelmed, how can you still do quality and safety? My response is, you are doing quality and safety right now. You're identifying what your goals are. You're prioritizing your resources. You're looking at what our existing structures and processes are. You're making modifications. You're doing it much faster, right? It's that faster pace of change and innovation. And you're measuring your outcomes. And you have to continue to apply the same approach, whether we're in a pandemic or you're in normal times. So we have seen around the globe, hospitals and health facilities have done things like stopped elective procedures or limited certain types of patients coming into the hospitals. They've reused their facilities for different reasons, and that's exactly appropriate. From the JCI accreditation, the survey process, we've done the exact same. We've identified, we've had to identify, and we've asked organizations, where are you unable to focus on during this pandemic? And we've recognized that as part of the survey process. We've had some allowances for organizations that have said, we can't do elective procedures, we're not doing certain things. We recognize that. There's certain processes that organizations have had to stop just to be able to provide safe care. So we recognize that. We know organizations are doing it. I still go back to use your quality tools that you have. Prioritization has always been part of it. No one has endless resources. No one has endless staff, right? So we've always prioritized what we can do. But I also want to bring back that point of monitoring. So as you're going through this, make sure someone is documenting when you're starting or when you're stopping something, and keep track of those outcomes. We have seen some new types of safety events that have come up because of the pandemic that aren't even related to COVID-19. We've had misdiagnoses. We've had delayed treatment of care. We've seen a huge drop in preventive health care, such as immunizations in pediatric populations. So keep track of those, monitor those, because when you get back to some semblance of normality, you'll want to go back and address those things that you might have missed. Francine, anything to add?
So Kathy, thank you. You're right on target, I believe, with all the, how we've had to refocus things. And then the other thing that I would like to include in this discussion is a big thank you to every single one of you that has been participating in care delivery during this pandemic. We have to take care of our caregivers. There is extreme fatigue in our workforce right now because of everything that our hospitals and ambulatory staff has been going through, and we can't begin to get back to what the new normal is going to be until we start to take care of our own physical and mental health as well. So reprioritizing, recognizing the fact that everybody has gone through an extreme event that's unprecedented in our lifetime, and then just slowly transitioning back into what the new normal will be.
Thank you. Jadi jawabannya adalah yang pertama, tentukan prioritasnya, karena kita tahu bahwa di masa perubahan ini semuanya harus berubah. Jadi nggak mungkin kita melakukan perubahan secara sekaligus kepada semua hal yang harus kita rubah, tentukan prioritasnya. Tapi yang disampaikan dari kedua pembicara tadi bahwa jangan khawatir bahwa sebenarnya kita sekarang itu sudah melakukan kita tetap melakukan pengamatan atau monitoring terhadap mutu dan keselamatan pasien. Kenapa? Karena secara pandemik ini kita sebenarnya punya tujuan kan, kita mau ngapain. Jadi tentunya dengan COVID ini kita punya tujuan-tujuan baru yang kita tetapkan di rumah sakit dan juga di puskesmas atau mungkin di lab dan tempat yang lainnya. Apa tujuannya? Mungkin kalau di rumah sakit atau di puskesmas, jangan sampai ada staf kita yang misalnya terinfeksi oleh COVID misalnya, di rumah sakit atau di tempat dia bekerja. Itu kan salah satu tujuan sebenarnya. Kemudian ada juga modifikasi yang kita lakukan. Kita pakai APD gitu ya. Kemudian ada beberapa jalur-jalur pasien yang dilalui juga kita rubah. Kita bedakan ada yang zona COVID, ada yang zona non-COVID, itu juga satu modifikasi yang sudah kita lakukan. Kemudian kita juga melakukan pengukuran-pengukuran untuk keberhasilan. Kita juga pengen tahu kan, berapa staf kita yang terinfeksi, berapa pasien kita yang sembuh karena COVID, berapa pasien kita yang meninggal karena COVID. Ada nggak jumlah kasus baru yang terjadi? Jangan sampai tempat kita bekerja jadi suatu klaster untuk COVID misalnya. Jadi sebenarnya semua yang kita lakukan itu selama ini juga merupakan upaya mutu gitu. Jadi jangan dianggap bahwa selama COVID ini justru kita tidak melakukan kegiatan mutu apapun, tapi sebenarnya kita melakukannya dengan cara yang berbeda. Jadi menurut beliau berdua, prioritaskan saja apa yang mau kita lakukan berikutnya dengan pencatatan yang baik. Karena kalau kita punya semua catatan yang baik tentang apa yang terjadi selama COVID ini, itu akan menjadi dasar kita untuk berubah dan juga kalau di GCI itu mereka dibilangnya sebagai room for improvement. Jadi apa saja hal-hal yang bisa kita rubah dalam room for improvement tadi untuk kedepannya kalau terjadi lagi pandemi seperti ini atau mungkin disaster preparedness apa yang harus kita persiapkan pada saat terjadi pandemi COVID ini. Kira-kira seperti itu. Ya. Thank you for your questions. For your answer. And then another question. This is for Catherine. How we could improve our quality management, creative thinking in the management process. Because I think you mentioned it in your presentation about the creative thinking. So someone here would like to know what kind of creative thinking in quality management 4.0. Please, Catherine.
Sure, thanks for the question. This is an opportunity with the pandemic as we've had to do everything new and innovative and be creative. I'm hoping we keep this energy going moving forward. Creativity is we're just limited by our own imagination, right? So there's so many different things that we can do, and the pandemic has allowed us to be creative. I am actually volunteering in a vaccine clinic right now, and it's amazing what we've done with volunteers, with facilities that we never provided healthcare in. I'm working in a big exposition center with managing coordination between public health, between private institutions, between different departments such as police and security, healthcare providers, transportation. So we can be creative when we are faced with disasters like we're facing right now with this pandemic. We just have to think out of our box, right? So as you ask me, how can you be creative in a management process? I go back to, I like to think simple. And my favorite slide is one that I shared with you, that structure, process, outcome slide. And that for healthcare, it identifies those structural elements, leadership. And for me, I think of structure, things I can touch, they're nouns. So people, leaders, the workforce, your finances, your HIT, and then your processes are your verbs, right? Things that you're doing. So as you want to think creative, get the right people in the room. And the right people in the room is not just your managers, but you might want to include those managers because you're going to talk about your management process, your leaders, but get those frontline staff in the room and think creatively. How about a patient? How about a community member? How about someone from a completely different industry who's done things differently than healthcare, and bring them into the room to talk about what's a creative structure we might look at, what's a creative process. And we've done these over the past year. So I think we have this opportunity with COVID to kind of stimulate us to be more innovative. And it's just a matter of pulling the right people together, having that a leadership support to do it. Innovation will not happen. Creativity will not happen if you're in an organization that the leadership, the culture is saying, no, we're doing things this way. But I don't think anyone is doing things the same way they were doing them a year ago, right? Or a year and a half ago. We're all doing things in a creative, innovative way. So ride that wave, keep moving it forward. And use that slide. Think of structure and process, and that will lead you to outcome. And think innovatively. Think outside of healthcare. Think outside of doctors and nurses and pharmacists. Bring a patient in. Bring your community members in. And think of different ways that we can do the work that we're doing.
Okay. Thank you. Jadi selama masa pandemi ini sebenarnya sudah memacu kita untuk menjadi sangat kreatif untuk tetap memberikan pelayanan, ya karena kan seperti biasa pada kondisi kepepet itu memang biasanya manusia menjadi sangat hebat ya karena disitulah semua hormon-hormon kita bekerja pada saat kita kepepet. Jadi saran dari beliau adalah libatkan pasien, kemudian libatkan komunitas yang ada di sekeliling kita. Dan kita coba bahas bersama-sama apa yang bisa kita buat agar kita menjadi sesuatu yang tetap dapat memberikan pelayanan atau pelayanan itu tetap berlangsung sementara pandemi COVID ini juga tetap jalan gitu ya. Jadi berjalan dengan paralel. Dan kreativitas tadi tidak terbatas pada satu hal saja, tapi kalau dilihat dari tadi slide-nya beliau, dari mulai struktur, kemudian proses dan outcome-nya, itu semuanya memiliki step-step yang dapat memiliki kreativitas sendiri di dalam bagian-bagian tadi. Jadi kalau kita bisa melakukan suatu kreativitas di dalam struktur, proses, dan outcome kita selama masa pandemi COVID ini, maka itulah sesuatu yang sebenarnya membuat kita menjadi mampu bertahan di dalam situasi pandemi COVID ini selama berlangsung. Yeah. Thank you, Catherine. So this is the next question. I think both of you could answer this. This is Catherine's slide, but I think Francine will also be part of it. How to building a system to be the high reliable organizations.
Okay, so I'll go ahead and I'll give it a start. One of the things, well, there's a number of things that we need to do. And whenever there's something new, we have to start by learning about it, reading about it. Dr. Mark Chasen, the president and CEO of the Joint Commission, has published a few articles on this topic. So I would encourage people to start by learning as much as you possibly can on the topic. And then when it comes to high reliability and how are we going to begin to prevent some of these things that have been happening that we've always accepted in healthcare. For example, think about IHI and the 100,000 lives campaign that started probably about 20 years ago or whatever. At that time when we started to look at central line infections, we accepted the fact that if somebody was going to have a central line infection, a central line placed, that there was a high possibility, 30–40% possibility of that patient having a serious infection. And we just accepted that as part of healthcare. But by focusing on it and saying, we aren't going to accept this anymore, and we need to find methods, we need to find ways to prevent this from happening, we have drastically reduced the number of central line infections that occurred. And it's only by this type of diligence, by taking these topics and saying, we're going to fix this, because as human beings, we can. So to expand a little bit on Dr. Kathy's previous response, healthcare leaders need to listen to their staff. And when the staff says, my idea is that, we consider doing this. Instead of us saying, oh, I don't know if we can do that, we need to say, all right, how are we going to do it? What are the steps we're going to take? When you look at people like Steve Jobs and what he did with Apple, I mean, if anybody from my generation would have thought that we'd be taking, pictures with our telephones, we wouldn't have imagined that when we were children, but somebody did. And instead of saying, oh, I don't think we're going to be able to do that, they said, well, how could we do that? Let's talk about it. Let's do it. Another thing is we cannot be afraid to fail. We have to try things and determine whether or not they're going to work, because some of the things that we think might be outlandish might actually be quite successful. So we have to attempt those things. As Kathy said, Dr. Kathy said, we need to move out of our comfort zone and try these different methods so that we can see if they're going to succeed or not. And then we have to take away, another thing that we have to do is we have to take away that shame. If a mistake occurs, we should be sharing that information right away. So even if something bad happened, what we have to do is we have to break that apart. We have to analyze it to see why it happened, what caused it to happen. It's not because somebody, went to work and did a bad job. It's typically because the process failed us. So we have to, first of all, share that it happened. Don't be ashamed. And then work through what went wrong and what we can do to prevent that from happening again. All of these things will contribute to us eventually getting to high reliability.
May I translate it first? Jadi sebenarnya untuk menjadi suatu organisasi yang dapat diandalkan, dalam hal ini tentunya secara mutu dan akreditasi, yang pertama adalah pemimpin itu harus mendengarkan. Jadi kalau misalnya dia menyadari bahwa, atau ada anak buahnya yang menyatakan bahwa angka misalnya infeksi karena central line, jadi ya biasanya phlebitis atau phlebitis yang terjadi atau pemasangan central line yang terjadi misalnya itu mencapai 30% sampai 40% di rumah sakit, maka dia harus mau mendengarkan itu dari stafnya. Dan karena dengan mendengarkan itu, sebenarnya itu sudah satu langkah untuk menerima bahwa memang ada sesuatu yang harus diperbaiki. Jadi kira-kira seperti itu. Nah, dengan berani mendengarkan masukan dari staf tadi, yang pertama tentunya sebagai pimpinan itu adalah satu, pasti tadi ya nggak boleh marah. Karena di dalam budaya keselamatan itu pasti kita adalah non-blaming culture. Jadi kita justru tidak boleh marah, tapi kita justru harus mendengar apa yang sebenarnya terjadi dan kemudian kita berusaha untuk melakukan perbaikan ke depannya agar ke depan hal-hal seperti ini tidak terulang lagi. Kira-kira mungkin seperti itu, dan kalau sudah stafnya tadi antara hubungan yang baik antara leadership dengan staf tadi memang sudah terjalin, maka perbaikan-perbaikan ke depan itu akan sangat mudah dilakukan karena memang semua sudah ada dalam satu track yang benar, kira-kira seperti itu, atau track yang sama lah kurang lebih ya. Oke, and then Catherine, please if you would like to add something.
Sure, just add a little bit to Francine's discussion. We kind of walk through it through my slides. I mean, high reliability is, it starts with leadership, and leadership has to be committed to safety, and leadership has to set that vision. That is the role of leadership. The role of leadership is to set the vision for an organization, and by setting it at zero harm, or zero adverse events, zero falls, and someone asked me, zero missed opportunities. What that means is like zero missed diagnoses or zero missed, oh, I forgot to give that immunization during that visit. So misdiagnosis is a huge safety issue right now. So when we talk about the high reliability, it starts with leaders committed to safety, setting the vision, which creates the culture that's focused around, the term is preoccupied with failure. So I'm a mom, and my kids, whenever they come to me and say, hey, I'm going to go take a trip, my immediate worry is what's going to happen to them? How safe are they going to be? How are they going to get there? I'm preoccupied with failure and with safety. And that's what we need to be like in healthcare. We know the risks are always there. And that culture that listens to those frontline staff because the nurses and doctors at the bedside know way more than I do. So let's listen to them, bring their information to the table so that we can learn from it, and then use a evidence-based performance improvement, that engine of the house. Make sure you're continuously proving, using data to drive that forward. One of the examples from COVID that I heard loud and clear of an example of high reliability of a leader was in South Korea. There was a hospital leader who was interviewed, and he described learning from MERS in 2015. So that resiliency, learn from lessons, and they didn't do well in 2015 with MERS. They had many mistakes and mishaps. They implemented some changes in their process, their communication, their testing, their centralized control. But most important, he said, we maintained, quote, a constant fear of failure. A constant fear of failure. And he was interviewed because he had done such a good job, as well as anyone, of getting through the challenges and the crisis of this pandemic. So we high reliability, we're still all working on it. We're all trying to get there in healthcare. But if you think of those three things, the leadership, the culture, and performance improvement, they all tie together and will get us there to that visionary stage of zero harm.
Oke, thank you, Catherine. Jadi pada prinsipnya sebenarnya high reliable organization atau organisasi yang dapat dihandalkan itu sebenarnya sudah tidak ada lagi harm ya, jadi zero harm. Kebayang ya kalau kita jadi rumah sakit terus kita mesti bikin rumah sakit kita benar-benar tidak ada harm, itu pasti prosesnya panjang sekali. Jadi tadi yang sudah disampaikan juga oleh Francine, yang pertama adalah leadership. Jadi leadership itu sangat penting, bagaimana mereka bisa menjadi satu dengan seluruh stafnya, agar seluruh stafnya itu semuanya memahami bahwa ini merupakan sesuatu yang harus dicapai bersama. Dan yang paling penting juga, tadi juga Francine sudah sampaikan, adalah tidak boleh putus asa kalau gagal. Karena kalau kita pakai cara yang ini nggak berhasil, ternyata kita harus pakai cara yang lain. Jadi setiap cara itu tentunya akan membuat suatu proses tersendiri, tapi leadership dalam hal ini memang harus kuat, dan kemudian juga sambil jalan, sambil membangun sebuah budaya keselamatan di dalamnya, di mana membuat orang-orang kalau mau nge-report kepada leadership atau kepada pimpinan itu juga menjadi tidak takut gitu ya, bahwa kalau saya salah itu saya berani melapor, itu yang paling penting. Karena kalau kita sudah berani melapor dan kita tahu bahwa kalau kita melapor itu tidak ada sesuatu yang akan terjadi kepada diri kita, disitulah biasanya proses menuju highly reliable organization ini mulai dapat kita rasakan. Mungkin saya tambahkan sedikit, jadi kalau untuk pengalaman pertama survei, biasanya untuk pada saat kita mencapai suatu survei akreditasi kedua atau ketiga, ya kalau untuk yang join committee. Biasanya kalau udah survei kedua atau ketiga, kita akan melihat bahwa antara pimpinan dengan yang di bawah itu sudah satu jalan. Kalau survei yang pertama biasanya memang pengen lulus gitu ya, kalau di Joint Commission kalau saya lihat seperti itu. Tapi pada saat sudah survei kedua, survei ketiga, itu semua orang pada saat ditanya itu akan mengatakan suatu jawaban yang sama, dan itu akan align, akan cocok gitu. Itu yang biasanya kalau dalam survei itu kita cari bahwa suatu kondisi di mana ada suatu kesepakatan antara pimpinan dengan seluruh staf yang ada di rumah sakit untuk mencapai suatu quality improvement atau performance improvement tertentu. Jadi jangan khawatir untuk teman-teman yang tadi banyak sekali bertanya di masa COVID pandemi ini, Komite Mutu mau ngapain ya? Banyak banget standar yang nggak bisa kita nilai, banyak banget yang laporan yang lewat. Tadi juga sudah dikatakan, tetapkan prioritas yang akan kita ukur, yang penting data itu harus lengkap. Sehingga pada saat nanti kita melihat ke belakang mengenai penanganan pandemi COVID di rumah sakit kita, di puskesmas kita, di lab kita, disitulah kita punya data sebenarnya apa yang harus kita perbaiki ke depan. Jadi jangan justru takut untuk selama pandemik ini tidak harus bisa mengikuti atau tadi semua standar itu mungkin pengukurannya tidak akan tercapai, tapi prioritas kita sebagai suatu fasilitas kesehatan untuk tetap menjadi fasilitas kesehatan yang baik itu kira-kira seperti apa. Ya mungkin itu tadi karena banyak sekali pertanyaan mengenai bagaimana tetap menjaga mutu selama pandemi ini berlangsung ya. Jadi jangan khawatir teman-teman, yang kita lakukan semuanya sudah dalam jalan yang benar, nggak usah khawatir lagi. Okay, so another questions. So, okay. This is some of the new organizations that would like to be JCI accredited. They are asking you, what is the process to be JCI accredited hospital and how long should they prepare? This is someone from Jakarta, from Rumah Sakit IRC. They would like to know what is the process, what is the step they have to go first, and probably you can give general information about this from both of you, please.
All right, thank you. So this would be a really good question for John Yoon and Nick as well, because you know, a conversation with them could really help an organization understand you know, where they're at and what steps they need to take. But you know, to begin with, it typically takes an organization anywhere from 18 to 24 months to prepare for accreditation. And then we have some useful tools that are available online that are available that provide suggestions and recommendations for reading material and learning content. And then some tips that we would give you is to, as I mentioned earlier, you know, about how do you manage the facilities management chapter, you know, taking some of those same suggestions and recommendations and forming teams, teams specific to the chapters. So, you know, there's a chapter on medication management and safety. Have your pharmacy team really dig into that chapter and concentrate on medication safety. There's the infection control chapter. Have your infection control team really focus on that particular chapter. The chapter on anesthesia and surgical care, usually that that whole process is overseen by the surgeons and the anesthesiologists. So break this down into different components and have teams assigned to it with a larger steering committee or a larger planning team that facilitates all of this. You know, do an inventory of the policies and procedures that you have, determine what training your staff needs, and then learn how to perform your own tracers, which is the methodology that our surveyors use. So apply it, you know, as many of the methods that we use as possible to your own organization. So those are some tips and suggestions and a typical time frame.
Okay, do you want to add something, Catherine? No, okay. So, jadi kalau ingin menjadi satu organisasi yang terakreditasi GCI, saya rasa sama seperti akreditasi lainnya di rumah sakit. Jadi tentunya harus mempersiapkan tim dulu, kemudian timnya tersebut mempelajari standar-standar apa saja yang ada dalam Joint Commission, dan setelah standar-standar tadi dipelajari, kemudian coba untuk membuat kebijakan yang terkait dengan standar, ngikuti pelatihan juga, kalau memerlukan bantuan dapat memanggil konsultan juga GCI untuk melakukan pendampingan selama persiapan, dan prosesnya kurang lebih sama seperti itu, dan memakan waktunya rata-rata sih persiapannya itu kalau mau matang sekali memang 2-3 tahun. Jadi mungkin itu yang bisa saya sampaikan. Okay, so we're going to move to another question. So this is for you, Catherine. In your presentations, you're mentioning about the resilient safety culture. So what is the strategy to be the resilient safety culture?
So thanks for the question. So resilience is, the definition of resilience is, it's around being able to recover from errors, right? It's identifying, controlling, recovering from errors, and then creating kind of workarounds or new processes that will help minimize harm. A couple words that are often used are nimble, flexible, agile. So the concept of resiliency is one that, again, we've seen through COVID-19, all of those things, and we've all stumbled and made mistakes and had to recover, whether it's taking care of patients, whether it's taking care of the healthcare worker, right? We've seen some horrible situations where staff have been infected with COVID-19 because we didn't have the right PPE or we didn't have the right systems in place. So recognizing that, to err is human, that there are mistakes, but we have to pick ourselves up and move forward. So when we talk about that as part of the safety culture, one of those elements I described around safety culture was, well, there's 5 of them, but one was learning. So being able to learn from your mistakes, incorporate those lessons, right? And do something different, create a new process. When we talk about a safety culture that is a just culture, that when we make a mistake, which especially during the pandemic, many of us, made mistakes, we didn't know what we were doing, and we don't blame that individual, we don't discipline them, we say, oh my gosh, we're in a pandemic, or if we're not, what were the situations that led to that mistake? And let's take care of you as one of the staff. You may need some extra coaching or some training or repurposing, find a different role for you if you can't fill in a role. But it's not a matter of, most of us don't come to work wanting to do harm to our patients, right? So take care of the staff. It's part of that just culture. And then being able to be flexible, that's part of a safety culture, that flexibility. That's the same, that term is often used at the same time to describe resiliency. So resiliency is something we've seen demonstrated over and again during this pandemic, and it really is part of that safety culture. When you break out those 5 elements of a safety culture, resiliency is built in there. And a lot of this, honestly, you can reach that through accreditation. Accreditation helps you understand all these concepts I just described, honestly, that it's set up your structure, create a safety culture. We have that defined in one of our standards. And then that process of continuous improvement, that's that whole chapter on quality improvement and patient safety. The whole chapter is about that. So when you look at the accreditation standards, reflect on them in light of this last year and the pandemic, I see it as a great framework for you to build those structure, process, and outcome, but also with that sense of resiliency. Because though we do have surveyors that come in and we say, oh, you either met the standard or you didn't, we are always there about education. Right? Our whole purpose is to improve quality and safety in the global community. It's not to close hospitals. We're there around how do we help support organizations continuously improve. And that is resiliency.
Okay, very good questions. Jadi yang disebut dengan resilience itu adalah kalau bahasa Indonesianya tuh selalu improve gitu ya, selalu berubah untuk menjadi lebih baik. Nah ini suatu proses yang emang panjang dan nggak boleh bosen, karena kita kalau mau berubah selalu di mana-mana pasti ada resistensi. Jadi yang pertama, proses ini harus terus berjalan untuk melakukan perubahan dari mulai menemukan masalah yang akan kita perbaiki, kita lakukan monitoring sampai terakhir kita bisa menemukan solusi apa. Dan pada waktu kita menemukan solusi, ini akan terus berproses seperti itu sampai akhirnya kita menemukan suatu solusi yang tepat dan mencapai suatu pencapaian yang lebih baik lagi karena kita punya solusi yang lebih baik lagi. Dan untuk bisa mencapai hal ini tentunya perlu yang disebut sebagai fleksibilitas. Karena kalau nggak fleksibel, susah kan mau berubah terus gitu. Nah, sebenarnya proses inilah yang dilakukan selama kita melakukan akreditasi dan reakreditasi. Hanya saja memang karena tadi standarnya terlalu banyak, mencapai ini semua pada saat yang bersamaan tentunya sulit. Tapi itulah yang kira-kira bisa disebut sebagai resilient safety culture atau resilience culture yang ada dalam rumah sakit yang seharusnya menjadi satu dasar untuk budaya peningkatan mutu dan keselamatan pasien di rumah sakit. Mudah-mudahan sudah menjawab. Okay, so the next question will be for Francine. There are some questions about the Hospital Safety Index, how to use it. And then the second will be the Hazard Vulnerable Analysis, the HVA. How do you make a very effective HVA for organizations. Actually, we have 3 questions, but we can start with the 2 questions first. The Hospital Safety Index and the Hazardous Vulnerable Analysis. Please, Francis.
I'm not familiar with what they're asking about the Hospital Safety Index.
That will be the WHO index for the disaster preparedness one.
Okay. So we don't prescribe any specific tools, and so I'm not familiar with that WHO tool, so I'm not going to comment on it. But what we do require is that you use some type of tool to determine where your risks are. So that could be the Hospital Safety Index, or it could be a hazard vulnerability analysis. Now, how do you do this? And what you should do is pull together the folks with the most appropriate knowledge within your organization and put them all in a room together, and then go through what your various risks are. And then once you have that whole pool of risks, that whole list of risks, you should prioritize them as the ones that are most likely to occur. And then what you look at is how well prepared are we to respond to this? What tools do we have in place? What policies do we have in place? What education and competencies do our staff have? And then you put together an action plan. But I want to go back to that evaluation process with your your safety tool or your hazard vulnerability analysis. It is most important when you're doing this evaluation to be to really scrutinize yourself in a way that you are accurate on your preparedness, because the biggest mistake that I see is that organizations say, oh yeah, we've got a plan in place and we're prepared for this. And then when the disaster actually hits, all of that self-assurance that they had just kind of falls aside because the plan collapses. So don't be overconfident that you have all the steps in place. As Kathy said, go through this a little with a lot of caution in place, and err on the side of caution versus, oh yeah, we've got this. We can handle it. The other point that I want to encourage you to think about is consider every suggestion that people in the room put out there. And I'll give you an example. Sometimes when we invite somebody to one of these sessions and we're gathering a lot of information, somebody may get all excited and they hold up their hand and they say, oh, this could go wrong. And some of the other people in the room might dismiss them politely, but might say, oh, that's not going to happen here. We're not going to spend a lot of time talking about that because that can't happen here, or that won't happen here. And then Murphy's Law takes over, and what happens? It happens here. So don't dismiss anybody's thoughts. Talk them through, and really think through the process so that you've given it some good discussion and some good thought. And then don't expect your plan to be perfect. Because even though we all thought we had good disaster management plans in place and that we were prepared for epidemics, we've talked about Ebola, we've talked about MERS, we've talked about all of these other things that have been happening over the last few years. When we look back over the last 12 to 14 months, we were not prepared in a way that we thought we were, in a way that we had anticipated. So accept the fact that there are going to be flaws in your plan, but when you recognize them, they need to be addressed. So you can't say, well, this is never going to happen again, because it will. And the next step should be, how are we going to manage this when it does happen again, how are we going to respond better? How are we going to respond differently? So when you put all of those steps in place, it doesn't matter which tool you're using. When you put all of those steps in place, you're going to have a more successful disaster management process. There are tons and tons and tons of reading material and content out on this topic, because it is a very glamorous topic. People like to talk about it. There's whole conferences about it. So there are plenty of opportunities to learn, and then use this as a cycle. As I mentioned, you put together, you perform your risk assessment, you put together your plan and your interventions, you evaluate that, determine what went well, what didn't, and then you readjust and you start the cycle all over again. You must do this at least annually and have your evaluation ready for the surveyors so they can look at what you learned and talk about with them how you're going to adjust and move forward.
Okay. Thank you, Francine. So, jadi untuk Hospital Safety Index, beliau tidak akan membicarakan karena beliau tidak terlalu familiar dengan Hospital Safety Index dari WHO. Hanya yang disampaikan mengenai Hazardous Materials Analysis, jadi HVA. HVA itu sebenarnya betul-betul harus diperhatikan secara detail. Jadi detailnya itu apa saja? Ya tadi ya, namanya juga risk assessment. Jadi kalau risk assessment itu harus betul-betul dilihat tools-nya seperti apa, kemudian kebijakan yang kita punya seperti apa, kemudian edukasi dan training yang harus kita berikan kepada seluruh staf di rumah sakit seperti apa, dan itu semuanya harus merupakan satu kesatuan yang terus berputar atau berbentuk sebuah cycle. Karena kenapa? Menurut Francine, kita itu tidak pernah sempurna atau jangan pernah merasa bahwa kalau kita udah punya plan, kalau kita udah menetapkan satu HVA, itu kita udah pasti berhasil mengatasi suatu disaster yang terjadi. Itu enggak ya, karena di dunia ini ternyata tidak pernah ada satu rencana yang perfect atau sempurna. Jadi dengan rencana itu setidaknya kita sudah punya platform untuk kalau sesuatu terjadi kita mau melakukan apa. Tapi kita juga harus sadar bahwa dalam rencana tadi itu selalu akan ada perbaikan. Dan selalu lihatlah perbaikan-perbaikan yang kita perlukan dari semua rencana yang sudah kita buat dan semua yang sudah kita lakukan sebelumnya. Karena dengan rencana yang sudah kita buat tadi, kita akan terus memperbaharui rencana-rencana berikutnya. Jadi beliau berpesan bahwa mau menggunakan tools yang Safety Index ataupun menggunakan Hazardous Materials Analysis, itu dua-duanya sama gitu. Memang risk management ya sifatnya seperti itu, selalu berputar, tidak pernah berhenti. Kira-kira itu. And then another question for you, Francine. This is from one of the JCI accredited hospital as well. They acknowledge that the new 7th edition standard also addressing about the laser equipment. So probably you can give us a bit of general information of what kind of equipment was included in this laser equipment or laser chapter for the new 7th edition.
Sure. We've begun to realize that there are a lot of safety risks involved with laser therapy. So where in your hospital might you find laser equipment? Because the first thing that you're going to need to do is an inventory on where those pieces of equipment might be, and who's actually bringing the equipment into the organization. Is it being purchased and supplied by the hospital itself, or is it being brought in by possibly the medical staff? So some of the more frequent, some of the common areas where we find laser equipment might be in your eye clinics for laser eye surgery, the dermatology department for dermatologic procedures, the therapy departments, because sometimes therapy departments are using laser therapy. Dental clinics might have lasers in them. So do an inventory and determine where the laser equipment is. And then make sure that you have safe practices in place. Is there the appropriate PPE in those locations? Do you have the goggles for the staff, the goggles for the patients? Do you have signage to put on the doors so that when the door is closed and there's laser procedure going on behind the door, somebody doesn't accidentally walk into that room? Is the room set up appropriately so that there's no reflection off of things like mirrors or other shiny objects? The other thing that you have to consider is what happens if there is an event that occurs as a result of the use of the laser therapy or the laser treatment, the laser equipment. How does that get reported? How is that managed? So all of this is part of our requirements now, because we do appreciate the risks that come with the use of laser equipment within your organization. And Kathy, maybe you might have something to add, I'm not sure, but it is something that you really want to have a good handle on and be prepared to talk about during your survey.
Okay, sorry, I need to interrupt. Is this laser equipment is medical and non-medical? Because it's like the basic question from them. Is it included the medical and non-medical, or only the medical? And if the medical is lithotripsy, is one of them or not?
So now we're getting very, very specific, and you know, I would have to take a look at your specific equipment, and so you know, now we're getting into those minute details that you know, should probably be taken offline outside of the webinar.
Oh, okay. Thank you. Yes, please. If Catherine, do you want to add something? No. Okay, so the next question will be for you. Okay, so actually, this is a very basic question, but I think it's a very good question. How do we should develop a policy in a hospital? Because sometimes it's a top down and sometimes it's the bottom up. So which one is the best one from your point of view? Jadi ini ada pertanyaan mengenai bagaimana membuat policy di rumah sakit. Tadi ada di dalam daftar pertanyaan. Kita akan melihat jawaban dari Catherine. Please, Catherine.
Sure. So thanks for the question. Yes, we see this all over the globe where people just want to know, tell me how I write a policy. And then the next thing out of most people's mouth is, can I just take the policies from the hospital down the street? Because I know the person there and they've got great policies. Can I just take them? And the answer to that is no. But creating a policy, so I always tell people developing the procedure, the steps, the tasks, the process you want people to follow is the most important thing, right? Because what a policy is just a rule that says, you know, you must wash your hands, whatever it is. You must report sentinel events. That's just a rule, right? But how that happens is really challenging to define, and we need to do it in a simple way, in a standardized way, so that we get the same results every time. This is basic performance improvement, right? The whole purpose of performance improvement or process improvement is to standardize the work that we do so that we don't have a lot of variation, so that we get the same result every time we do something. So the writing of the policy, I always say, don't worry about that until you know, number one, what is your rule, i.e., what is your policy statement? What are you working on? So if it's hand hygiene, define that. All staff will wash their hands, right? Now, what is your process? What do you want people to do? And that's not easy. Hand hygiene is a great one. How do you want me to wash my hands? When do you want me to wash my hands? Where do you want me to wash my hands? What if I can't wash my hands? So we know writing that procedure is very challenging. And who does that? You need to include what we call the process owners, the people who do the process. Don't ask, and I'll pick on my colleague Nick there, don't ask Nick to write the policy and procedure on hand hygiene, he's not working at the bedside, right? So find someone, get that team together, identify what is the process we want to use, look at the evidence-based, right? You don't want to just make something up. Oh, I'm going to use shampoo, my hair washing shampoo to wash my hands. There's no evidence that that works in the hospital. So evidence-based, get the process owners, and then write your policy and procedure. So the writing the policy procedure, unfortunately, is what most of us go to first. It should be the last thing you do when you write a policy and procedure. Now, I said, don't take the hospitals down the streets policy and procedure. Well, you shouldn't, but many of us do share policies and procedures. But if you do that, make sure you go through that, and it needs to be the procedure that you use in your facility. So that's why we say don't borrow someone else's, because if they've done it right, they've created the procedure that works for their hospital, their facility. It may not work in your hospital or facility. If it is similar, you can use at least the work that they've done and modify it. But most importantly, get the people who are doing the process. Actually, first off, what is your policy? What are you working on? And you need to be really clear about that. Then write it out. Get those steps. I love to see flow charts or algorithms that are easy to follow, step-by-step procedure. Then you put it into a document. So there's a long answer to that simple question.
Thank you, Catherine. Jadi pesennya kalau mau nulis kebijakan buat Bapak-Bapak Ibu sekalian, jangan kopas dari rumah sakit lain ya. Kita sering banget kalau mau akreditasi terus kopas dari rumah sakit lain, karena rumah sakit lain prosesnya berbeda dengan rumah sakit kita. Dan mengenai caranya, ya itu terjadi di mana-mana seluruh dunia ya, kopas bukan cuma di Indonesia, jadi nggak usah tenang aja, lemesin aja. Ya memang begitu, kadang-kadang mesti ngambil dari orang dulu, setelah dibaca-baca, iya ya kayaknya benar juga gitu, terus baru kita modifikasi sedikit gitu, tambal sulam sedikit. Jadi kalau menurut beliau, baiknya seperti apa, yang pasti dalam bentuk tim. Nah, timnya itu mau bottom up atau mau top down, itu tidak masalah gitu. Karena menurut beliau yang penting adalah proses apa yang ingin distandarisasi itu sudah sesuai seperti yang dibutuhkan oleh organisasi tersebut. Jadi nggak harus misalnya direktur yang harus menentukan seperti apa, atau misalnya staf yang menentukan seperti apa, tidak seperti itu. Tapi apa yang mau dibuat menjadi satu tujuan yang tercapai. Misalnya kayak cuci tangan. Cuci tangan itu mau tercapainya seperti apa gitu, mau ambil 6 langkah dari mana, nah itu silahkan gitu loh. Jadi mau ngambil guidelines yang dari mana, nah itulah yang ditentukan bersama sesuai dengan tujuan dari organisasi masing-masing. Karena organisasi tidak semuanya memiliki tujuan yang sama dan kebutuhan yang sama. Yang paling penting sih kebutuhan kalau menurut saya, karena kebutuhan itu walaupun prosesnya atau judulnya sama, tapi prosesnya itu pasti berbeda. Ya, dan sekali lagi memang nggak bisa ya di copy paste. Begitu di copy paste nanti nomor teleponnya aja ternyata bukan di tempatnya gitu ya. Sering kan kalau kita survei, terus ini nomor telepon emergency siapa gitu ya, bukan di Jakarta, bukan di mana, dari mana gitu. Ternyata temennya dulu di rumah sakit yang sebelumnya gitu, jadi copy paste seperti itu. Nah, hal-hal seperti itu yang harus betul-betul kita lihat dalam membuat sebuah kebijakan, supaya betul-betul memang yang penting tujuan organisasi kita sih, jadi bukan mengenai apapun gitu. Tujuan kita tuh sebenarnya kita pengennya seperti apa. Okay, so this is also another questions. So this is for Francine. During emergency, Francine, which one do you think is better? Using the standards of the accreditation as a base for our decision, or using our internal policies? This is a very technical questions, but this is one of the questions for you.
So the standards are written at a very high level, and they're not very prescriptive. So and the standards can be applied anywhere across the globe. So Those are, as I said, the highest level. And then your country has its own laws and regulations that apply in Indonesia. And then underneath that are your hospital policies and procedures that Dr. Kathy just described, because they give the specific instructions on, how things are done in your organization, who does them, when they do them, and how they perform the task. When it comes to your accreditation survey, or when it comes to the disaster situation, you're going to apply whatever is most appropriate for you. So, let's talk about fire safety. You have local laws and local regulations that say, all right, you have to have a certain amount of fire extinguishers based on how many meters are in each building. Our standards don't say that. Our standards say you have to, follow your laws and regulations. So your regulation's a little bit more specific. You follow that. But then your policies and procedures actually define to the staff, actually describe to the staff how they use those fire extinguishers. So, you're going to be using a component of each during the disaster response. The standards set the framework. Your laws and regulations guide you on how you do that, and your policies and procedures inside your organization tell your staff how they do it in your hospital. So I hope I've addressed that question in an appropriate way.
Okay. Thank you. Jadi pada dasarnya kalau standar itu sesuatu yang sifatnya lebih umum. Jadi pada saat suatu kejadian emergency, kalau kita mengacu kepada standar itu mungkin tidak akan menjawab semua yang harus kita lakukan. Yang harus kita lakukan apa, itu biasanya tercermin di dalam kebijakan internal kita sendiri di rumah sakit. Dan itulah kenapa kita tadi harus membuat kebijakan yang benar, sesuai dengan tujuan dari apa yang ingin kita capai. Nah, satu lagi yang tidak bisa dilupakan pada saat kondisi emergency adalah bagaimana aturan di dalam negara kita. Jadi untuk laws and regulation, karena di dalam negara kita masing-masing sudah ada yang mengatur bagaimana pada suatu kejadian, misalnya kondisi kebakaran atau kondisi pandemi Covid-19 seperti itu semuanya punya aturan sendiri-sendiri yang tentunya tidak bisa tidak dilakukan oleh rumah sakit. Sehingga mau tidak mau kita juga sebagai warga negara yang baik juga harus patuh terhadap hal itu. Jadi dalam hal ini tidak bisa juga mengacu kepada standar, tapi lebih baik mengacu kepada, kalau saya boleh menyimpulkan, mengacu kepada kebijakan internal kita yang sesuai dengan law and regulation atau kebijakan kita yang ada di dalam rumah sakit kita sendiri. Mungkin itu kira-kira yang bisa disampaikan. Kemudian ini pertanyaan, actually we have a lot of questions, so I need to really list down which one is really related to this webinar. Okay, there's also a question, what JCI would interested to have other socializations for the other standards other than FMS. So I have no idea who's going to answer that. Probably John, but he already left.
John and Nick. Nick will be taking notes.
Okay, Nick, is it possible for the other standards to have this kind of socializations for the Indonesian hospital?
Yes, I believe it is possible. We just need to work in details and how we can organize it. Give us some time and we could have a further discussion onto it.
Oke, so buat teman-teman yang mungkin baru ikut di standar yang lalu, di webinar yang lalu kita sudah melakukan sosialisasi untuk standar PPI ya sebenarnya Pak Do. Jadi in the previous event actually we are socializing our PCI standard during this pandemic management. So this time is also about FMS, so I don't know, maybe the next will be for the other standard. Jadi untuk yang nextnya nanti kira-kira tertariknya pada standar apa, mungkin bisa tulis di chat ini mau pakai standar apa yang kepengen tahu untuk yang selanjutnya. Karena MFK sudah, FMS sudah, PPI sudah. So I'm going to ask the audience which standards that they are willing to know or willing to learn more for the next event. So. Thank you. So next question will be for Catherine. This is from your presentations for your House of Quality framework. So from your House of Quality framework, what is the fundamental or the basic thing that we need to prepare if we are like the organization in the first step of achieving the accreditation?
So hard to answer that without knowing the organization, right? So it all depends on where the organization is. The first thing that we do when we come in, Francine and I come into a hospital to do any type of support is we do an assessment, right? So for us to be able to say, oh, start at the data, start at the quality management process, I wouldn't know. I'd have to do an assessment of the hospital. But in general, what I do is, and what I recommend to organizations, one, using that House of Quality. Those are kind of those 5 domains that I think are really important. But I use, and I see a lot of the comments coming in through the chat right now. They want update on QPS. Well, I kind of gave you an update on QPS today. Go back to that slide. Look at structure, process, outcome, and that is exactly how the QPS chapter is also organized. It gets into a little more detail around the quality department. So my first assessment, my question, if someone's building their quality department, is what is your structure? So I start at the top. Is your governance, your governing entity supporting quality? And I ask very specific question. Do your quality reports get on the agenda on the governing entities meeting? That tells me a lot. Does your governing entity, your board, your Ministry of Health, review quality data in their meetings? That's a simple question. And I go through all of those elements in that structure, process, outcome slide. And I ask about all of those things as it relates to quality. Do you have qualified staff? Who's running your quality department? Are they qualified? Have they been trained? And then you get into the processes. What process do you use for quality? Are you using a standardized improvement method? Do you use PDSA? Do you use Lean Six Sigma? What method do you use? And have staff been trained in that? Is it used across the organization? Can you show me examples of some improvement projects you've done using that methodology, right? And then it takes you to your outcomes. Show me what measures you're looking at. Tell me about specifically your patient safety outcome measures. Do you defined sentinel events? Do you have incident reporting systems so that you collect data on safety events? But I also look, remember my 6 domains of quality? I look at all of those measures. Do you collect that? And then what are you doing about it? It's one thing to collect data. How are you learning? Are you a learning organization? From all that data, feed it back into your improvement process and do something to correct those processes that are not working, that you're not achieving those outcome results, right? So look at your House of Quality. That kind of gives you a sense of what I think is an ideal quality management system. But use that slide, that structure, process, outcome, and that really helps you walk through what is an effective quality program. And it's reflected in that QPS chapter.
Okay. Thank you, Catherine. It's a very good question. Jadi untuk membangun sebuah framework quality, memang nomor 1 yang paling penting di dalam rumah sakit adalah data. Dan begitu data itu sudah terbentuk, maka data itu harus dapat diputar untuk menciptakan suatu improvement yang memang saling berkesinambungan untuk selanjutnya. Jadi yang paling penting menurut beliau adalah itu, dan kemudian kita lakukan continuous quality improvement, dan di dalam continuous quality improvement itu secara tidak langsung semua yang ada dalam framework tersebut juga akan ikut berputar. Kira-kira itu mungkin yang bisa disampaikan oleh beliau. Dan mengingat waktu juga sore ini, jadi mohon maaf kalau tidak semua pertanyaan dapat kita jawab, tapi hampir semua pertanyaan-pertanyaan yang penting-penting dan ada beberapa pertanyaan yang saya gabungkan, kita coba untuk jawab sore ini. Mudah-mudahan bermanfaat. Untuk selanjutnya saya akan kembalikan acaranya ke Mbak Evi selaku MC dari webinar kita sore ini. So, silakan Mbak Evi.
Oke. Terima kasih banyak Dr. Dini, luar biasa sekali. Thank you for Catherine and Francine. Luar biasa kalau di Indonesia ya, tolong disampaikan Dr. Dini, daging semua isinya. Dan termotivasi sekali dengan tip and triknya. Bahkan tadi yang bagi saya ya sangat berkesan, kalau kita memang nggak bisa ya pelajari gitu. Oke, luar biasa sekali. Sekali lagi terima kasih Dr. Dini. Ya.
Saya translate bentar ya Mbak Evi.
Thank you.
So, the MC said that both of you are very inspiring and give it the biggest chunk of quality for every one of us. So we learned a lot this afternoon. So they're really looking forward to have you in the next webinar. Thank you.
Thank you.
And we thank you for the opportunity very much. Thank you so much. And Dr. Dini, thank you for translation for us too. We appreciate it very much. So thank you to everybody.
You're welcome. Silakan Mbak Evi.
And I'll say terima kasih.
Yes.
Is that right? I remember that from being there.
Thank you, Catherine. Terima kasih sama-sama Catherine. Ya, baiklah Bapak Ibu sekalian, luar biasa sekali ya. Tentu saja para pembelajar tidak akan pernah puas untuk menimba ilmu. Dia memiliki jiwa yang haus akan ilmu pengetahuan dan pembelajar akan terus belajar hari ini, besok dan seterusnya. Jadi jangan lewatkan ya Bapak Ibu untuk webinar selanjutnya dari Komite Mutu dari Komite Nasional Keselamatan Pasien kita. Baiklah Bapak Ibu, di penghujung acara ini kita ucapkan puji syukur kepada Tuhan Yang Maha Esa karena acara kita dapat berlangsung walaupun di awal tadi ada sedikit gangguan, tapi dapat teratasi. Nah, untuk itu kami mohon kepada Ibu Direktur kami, Dr. Gigi Fariha Hanum, masih monitor Ibu, izin? Izin Bapak Ibu dari Subditmar bisa.
Silakan.
Ya, oke. Mungkin ya.
Saya monitor tapi dari mobil ini.
Siap, silakan Ibu. Baiklah.
Mohon maaf ya karena ini ada tugas dari luar sehingga semuanya harus dikerjakan secara berbarengan.
Baik,
sekali
Ibu.
lagi kami mengucapkan terima kasih ini Dr. Dini yang
mohon maaf Ibu, mungkin kameranya bisa dibalik.
Kameranya kenapa?
Iya, kameranya menuju ke kursi depan, Ibu, izin maaf.
Sebentar.
Baik, tidak apa-apa, Ibu.
Saya tutup aja. Oke.
Ya, baik, Ibu.
Baik. Ya, sekali lagi kami mengucapkan terima kasih atas fasilitasi dari pertemuan dari siang sampai sore hari ini tadi ya. Luar biasa, saya kira pembelajaran yang kita dapatkan. Jadi kita semua tidak boleh lelah-lelah untuk belajar dari siapapun, begitu termasuk ini dari GCI Consultant. Kepada spesial untuk Dr. Dini juga kami mengucapkan terima kasih ya yang sudah memfasilitasi ini. Kemudian juga untuk Komite Nasional Keselamatan Pasien, beberapa program-program ke depan akan kita tunggu bersama, termasuk bagaimana kita nanti harus melakukan quality improvement di seluruh fasilitas pelayanan kesehatan. Jadi kalau sekarang lebih banyak fokus pada rumah sakit, mudah-mudahan di webinar berikutnya kita akan bertemu untuk bagaimana kita melakukan quality improvement termasuk membangun budaya keselamatan pasien di FKTP, di laboratorium, dan di fasilitas pelayanan kesehatan yang ada lainnya. Sekali lagi kami mengucapkan terima kasih dan untuk seluruh panitia juga luar biasa kerja kita pada hari ini. Mudah-mudahan bermanfaat untuk kita semua. Terima kasih semuanya. Selamat sore. Assalamualaikum.
Waalaikumsalam, Ibu Direktur. Terima kasih.
Terima kasih.
Iya, baik. Baik Bapak Ibu sekalian, karena waktu juga yang akhirnya memisahkan kita. Karena di penghujung acara ini sekali lagi saya menyampaikan bahwa pengumuman pertama, link materi sudah di-share baik di chat room maupun di YouTube. Jadi untuk di YouTube Bapak Ibu bisa mengulang lagi. Jika ingin mendengarkan kembali, siapa tahu ada yang terlewat, itu bisa mendengarkan lagi di link di YouTube kami, akunnya Peningkatan Mutu Pelayanan Kesehatan. Sekali lagi YouTube kami di Peningkatan Mutu Pelayanan Kesehatan. Baiklah Bapak Ibu sekalian, di akhir acara ini saya ucapkan sekali lagi terima kasih untuk Ibu Moderator, narasumber maupun
siap ikut.
Kemudian juga Dr. Bambang yang dari awal sampai akhir juga tetap mengikuti, Dr. Kuncoro, dan seluruh anggota Komite Nasional Keselamatan Pasien. Baiklah Bapak Ibu, akhir kata kami ucapkan selamat berpisah, mohon maaf atas segala kekurangan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih banyak.
Terima kasih
semuanya. Izin
Terima kasih.
Semuanya, terima kasih. Sampai
Thank
ketemu
you for
nanti
all the
di pertemuan
speakers.
berikutnya.
Thank you.
Thank you. Bye, everybody. Have a
Terima
good weekend.
kasih.
Have a good weekend.
Thank you.
Thank you so much.
So much.
Terima kasih Pak Nik.
Thank you so much. Keep health and safe.
Thank you. Belum.
Terima kasih semuanya.
Terima kasih Bu. Tunggu. Recordingnya stop.
Terima kasih, Dok.
Terima kasih Bapak, sehat selalu. Sampai ketemu ya Bapak Ibu di webinar kita selanjutnya. Dan akan kami share, baik melalui versi atau dari Dinas Kesehatan per provinsi, juga akan kami share. Baik, Bapak Ibu sekalian, sekali lagi terima kasih dan izinkan kami pamit, seluruh panitia pamit, mohon maaf atas segala kekurangannya. Sampai bertemu lagi di acara yang akan datang dan akan kami share nanti untuk linknya. Saya izin live. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Bu MC.